Hello, everybody. My name is Steve Edelman. I'm going to do a quick introduction to Kelly Close before Kelly officially opens tonight's forum. We've been doing this forum for almost a decade and a half, and they've all been face-to-face. They're all typically the last night of the ADA, and it's a great night to get together. So this year it's virtual. We're doing the best we can, and we hope you've all enjoyed the ADA meeting and that your rear end is not too sore. So I would like to do a very quick introduction of Kelly. And if we can go to the very first slide that shows a picture of Kelly and her family, that would be awesome. Okay. Well, I'm going to start the intro. And when Kelly's picture comes up, I will get back to her family. Okay, well, many of you don't know Kelly very well. You just know there's this woman who runs around, reports about diabetes around the world, and doesn't require any sleep. Maybe she does, but she doesn't get any sleep. And we rely on her publications very much, and with her extensive team. Now, Kelly grew up in a small town, St. Paul, Nebraska, with only, there it is, with only 2,000 people, if you can believe that. I mean, Kelly can cover that amount of people in 1 hour with her connections. And there's her husband, Johnny, and she has 3 kids, Coco, Lola, and Tino, short for Valentino. And I think it's really a nice picture because we usually don't see Kelly, you know, the softer side of Kelly, the family, the mother, and the wife. So it's amazing what she does. Now, she got her undergraduate degree in economics as well as English at Amherst. She got her MBA from Harvard Business School. When I was practicing my speech, I accidentally said Harvard Medical School, but either one, she's a honorary doctor at this point. And then she started Close Concerns, reporting the important news about diabetes. She started DQ&A, a company that does questionnaires to patients and providers to improve diabetes care. And then her not-for-profit wing, diaTribe, focusing on patient education and advocacy. So I first met Kelly decades ago when she volunteered to be in a study, believe it or not, implantable glucose sensor that Dexcom was doing at the time, which morphed into their subcutaneous sensor. And now, obviously, we have other companies working on implantable sensors. So with that, I want to go to the next slide and give a remembrance to my good friend and colleague, Robert Henry. Many of us know Bob Henry. He's been a panelist for us many times, but more importantly, he contributed a great deal to the field of diabetes. He's been a mentor to so many of us diabetes folks out in the world, including Vanita and Jeremy and so many others. And I think most of all, he's a real individual. He's a gentle giant. He would give you the shirt off his back. And if there were more Bob Henrys in the world, it would be a better place for sure. And there's his long-term partner, Deneen. And there's a great picture of Bob when he got married to Deneen. And what took Bob's life in January of this year was a rare neurologic condition that boil it down to bad luck. But we miss him, and he certainly has left his mark. So with that, I'm going to let Kelly officially open the program, and you can go to the next slide.
Steve, thank you so much for this warm and generous introduction. It is amazing how long that we've been doing this and been surrounded by so many amazing, amazing colleagues of yours. And I follow all of you all around the world. And now for me, having been given this opportunity as somebody who's had diabetes almost 35 years and to have been able to watch all of you, the impact is incredible. So on behalf of the diaTribe Foundation and taking control of your diabetes, welcome everybody to the 14th Annual Diabetes Forum. My name is Kelly Close, and we are really so thrilled to have you here with us tonight. The past few months have brought forward huge challenges in the world. COVID-19 brought forward a virus, along with a pandemic of loneliness, mental health, and unemployment. We must also really acknowledge the tragic impact of COVID-19. People are dying. And in many ways, COVID-19 has exacerbated problems that have existed for a long time, including racism. And there's a lot of pain in the world right now. And when it comes to diabetes, all of these challenges play a huge role. Racism, COVID-19, mental health problems, cost and access. 2,700 people were diagnosed with type 2 diabetes today, and yesterday, and the day before that. And we can't talk about diabetes without talking about the many systems that affect it. So this is the really important context for our discussion today. My dear friend Nancy Kane, author of Forged in Crisis, leadership expert, she often talks about how true leaders prove themselves, maybe mostly during times of crises. And today, along with me on the panel, are 6 incredible leaders whom I admire so deeply. 6 leaders whose work and passion is gonna help us reach a better future. And Steve is co-moderating, but an incredibly important part of the panel because everything that he understands, all of his history, and all of his ability and ambition for all of us to do the best possible that we can. And he's taking us to a higher level. If you can't all feel it, it's happening. So before I introduce everyone, I just really want to say thank you so much to the sponsors who made tonight happen. They're really helping TCOYD and diaTribe grow. So our first-in-class sponsors, that's AstraZeneca, Dexcom, Lilly, OneDrop, Essentia. I'd like to go to the next slide. Thank you for making this all happen. So that's the first in class. And I just want to say of the first in class, AstraZeneca, Dexcom, Lilly, OneDrop, they are with us by our sides. They're helping us grow in as big a way as possible. And supporting sponsors, Abbott, Amarin, Essentia, BD, Janssen, Medtronic, Merck-Pfizer partnership. And then we've got on the next slide, more supporting sponsors, Novo Nordisk, Prudential, Tandem, Xeris, Zealand Pharma. On the next slide, and this is just so much support, it's amazing. The next slide, forum sponsors, that's BI Lilly, Gluco, Insulet, Roche, Stability Health, WellDoc. The learning and community here tonight would not be possible without your support. And we are really eternally, eternally grateful. And the next slide. So Steve, it's so impressive that Steve has done this for decades now, has been working on diabetes, the biggest public health problem of our time, while making sure that everybody is learning as much as possible in a very dizzying field. And when Steve came to me almost 15 years ago now, we want to bring more people together in the diabetes field, but we never imagined having thousands of people, here with us like tonight. And we have among us now leading researchers, clinicians, advocates, educators, people with diabetes advocates, even a policymaker or two out there. We're so excited to have more perspectives and backgrounds kind of in the room than ever before. And so now I want to introduce the rest of the panelists. We have Dr. Irl Hirsh, Professor of Medicine at University of Washington Medicine Diabetes Institute. Irl has helped Steve and me and so many of you so many times, and Irl has taken all of us higher, and he has really been so incredibly ambitious for the field. And I don't know, just just seeing this meeting, I want to hear sometime here, Earl, how many times you have been at the podium at this meeting, and you're always thinking about making all of us better, and always doing it as someone who has diabetes and brother of someone with diabetes. Next, we have Dr. Jeremy Pettis, Associate Professor of Medicine at UCSD, Division of Endocrinology. And Jeremy, I was talking to Steve before just about how we wanted to watch you go up here. It's amazing how you came onto the field and were just lightning smart. And now hearing you talk at every conference that I go to about every end of the system that is type 1 in particular, it's amazing to watch. And hearing you talk about the cures, the multiple cures to diabetes, hearing you talk about technology, and hearing you speak truth is something we're so excited to be able to do tonight. We're so excited also to have Dr. Eugene Wright. It's been a little while since Dr. Wright has been on the panel with us. He's consulting associate in the Department of Medicine and Community and Family Medicine at Duke Southern Regional. He has committed so much thinking about how the field needs to move forward in terms of primary care in particular, and in terms of really helping us think about, you know, there's the research, and then there's the translation of it, and there's the design and the delivery. And we can't say thank you enough to him for being with us. He's turned us down for a couple of years in a row, and now he's back. We are also so happy to see Dr. Vanita Aroda with us here tonight. She's such a powerhouse, Director of Diabetes Clinical Research at Brigham and Women's Hospital and Harvard Medical School. This is somebody who is also, we've had the pleasure of watching her start her career, you know, watching her bring up always so many interesting questions. She's somebody that people really look to increasingly in the field, and known as an amazing clinical trialist. And it's just an honor to have you back with us, Vanita. And Dr. Wil Cefalu, now Director of the Division of Diabetes, Endocrinology, and Metabolic Disease at the NIDDK. It's really, you know, it's so fancy, Will. I mean, it's so fancy what you're doing now. We have so many reasons to thank you for all of your leadership, going back to Pennington, and even before that, and then at ADA, watching you make the standards of care come alive. And again, you as well, being so focused on the people that sometimes the rest of the world wants to forget about. So we were thrilled that you said yes to Steve, and that you would be back with us tonight. And we're really excited to hear how some of your experiences have been on the research side. I'm so lucky to have gotten to lead this panel with Steve for so many years now. And just the next slide now, if you would, I wanted to just tell you a little bit more about diaTribe. So our mission is to improve the lives of people with diabetes and prediabetes through education, advocacy, and gathering people together, like tonight. And if you can go to the next slide, please. We publish information. We publish information really because knowledge is power, right? And through our newsletter, we really aim to keep our communities safe and as healthy as possible. And the next slide, please. COVID-19 has brought together, really COVID-19 has brought forward rather, unbelievable challenges, unprecedented challenges. You know, our team has put together a list of all of the resources at diaTribe.org/COVID-19. You know, innovation is necessary for the field to move forward, but we also believe it means nothing if it doesn't get into patients' hands, as does everyone on the panel tonight feel that way. So see diaTribe.org/access for steps companies are taking and many organizations are taking to make their medicines and technologies accessible. a big part of how we built DiaTribe is through our associate program across our family of organizations. And I was just only a co-founder at DQ&A, but watching DQ&A grow with Close Concerns, and then DiaTribe has only been a nonprofit since 2013, and we're so lucky to be here through the help of the Helmsley Charitable Trust first, and through so many other organizations as well, who have helped us grow and helped us kind of build the whole, knowledge is power. And people sometimes say, how do you do it? And I say, I'm just sort of the nominal leader. I get to work with the most amazing group of people, senior leaders, amazing at DiaTribe. That is Jim Carroll and Caroline Pavajan, in particular, our COO and Chief Strategy Officer. And they are stewarding an organization with many other leaders now kind of in and around us through our advisory board, but they have all helped us really watch dozens of our associates go back to medical school. They come with us, they come to work at DiaTribe, and we get them for a couple of years, and then they go join PhD programs, medical school, public health programs, and then later giving back so much to the fields of healthcare and diabetes just because of what they know. And because of the influence of all of you, it helps make them amazing classmates. So I want to say thank you hugely to DiaTribe, and Close Concerns and DQ&A do so much for us as well during this meeting and all year long. I want to share with you a little bit about our associate program. So let's take a moment so that I can show you a bit more about what our team is doing at the associate level and what you are supporting at DiaTribe. Everyone in this video is involved in DiaTribe's incredible work. And in particular, I wanted to say, as we started, look out for Sophie Coons. She started in the associate program 5 years ago and is now COO of all of DQ&A. And let's roll it.
Diabetes is an important public health epidemic because it affects hundreds of millions of people around the world. It not only has a big economic toll, but also has a huge impact on people's day-to-day well-being and can also cause a lot of debilitating long-term complications.
Through our education efforts, we are working with patients at an individual level and really providing people with actionable information to make them smarter about the condition. Through our advocacy and connecting efforts, we're working more behind the scenes at a society level.
So just 2 weeks ago, we reached 200,000 subscribers to our newsletter. It's been, very quick growth over the 5 or 6 years that DiaTribe has been around, but every time you hit send on that email, it's reaching that many people. It's pretty incredible.
Working at Close Concerns, it's really cool that we are able to make an online resource that encompasses all of the newest coverage in diabetes, which is kind of like a one-stop shop for a lot of people.
I came from a science background in college. Projects that I'm really enjoying working on at Close Concerns is a sort of stem cell research project. I've always been really fascinated by stem cells, and of course, that's a big part of new technology in diabetes.
So I work on the DQ&A international team, and we send surveys to people in 8 countries across Europe. And I am really excited because we're about to launch our first survey in Italy. So I think I'm most proud of that accomplishment to date.
It's really cool that all 3 organizations work so closely together and that we can interact with one another in our workspaces and also the diabetes ecosystem. I will constantly work with people from Close Concerns when we are partnering on different articles for DiaTribe Learn, so it's really cool that we're all able to share that together.
One thing I didn't expect is how big the diabetes stakeholder landscape is. I was very unaware about how many companies, scientists, conferences, and just technological innovation that's happening in the diabetes landscape on a day-to-day basis.
I didn't expect to have so much influence over the direction of the organization. Because we are such a small organization, everyone pulls an incredible amount of weight.
I honestly didn't expect how much responsibility and trust you're given so quickly, which is really unique for a first year out of college position. Having the work that you do like actually make an impact in the company and like in the world.
Right when I started, I hit the ground running. We're really making real world impact from day one.
This program sets up associates for success really in two ways. The first is by skills and work experience and all the things you learn along the way. But then also there's another side of things where the program really encourages you to pursue your future degree or your future career and really has a ton of resources in place.
The work environment at DiaTribe is incredibly unique. Everybody's always working together and everybody is a learner. Everybody is continuously kind of striving to be better at what they're doing.
This program is really special because it exposes you to an enormity of possible career paths in healthcare. I've gotten to work closely with researchers, with market researchers, with C-suite people at healthcare companies, closely with patients with chronic illness. So I think it really shows the wide variety of ways that you can make an impact on people's lives, and the support here is also tremendous.
I can't imagine another job where you're surrounded by so many people that are so intelligent and ambitious and hardworking, but also that connects you to leaders in industry and really get a very holistic picture of such a critical public health issue.
I am back, and gee, I am sorry that I could not play that video. We have one for you as well, and we probably won't have a chance to play it. Okay. I want to start off with a mission statement for taking control of your diabetes. It's TCOYD is a not-for-profit charitable organization dedicated to educating and motivating all people with diabetes and their loved ones to take a more active role in their health and to provide continuing diabetes education to medical professionals to better care for their patients with diabetes. We don't talk about our mission statement too much, but I think it's really important. The vision of taking control of their diabetes is for all people with diabetes and their loved ones to have full access to proper education and therapy in order to allow for the prevention, early detection, and aggressive management of diabetes and its complications.
Steve,
It all started.
you need to mute one of the. You need to mute one of them. Everyone's hearing an echo.
We're working on it. Thank you. Okay. This is the first brochure. It all started in 1995, 25 years ago. This is our first conference at the Taking Control Your Diabetes conference in San Diego, September 23rd, 1995. Then we spread to around the country. That first conference was so good. And I saw that people were so thirsty for their information that we have actually put on over 205 national conferences over the past 25 years in 81 cities, touching almost 380,000 conference participants all day long, from 8 o'clock in the morning till 5 at night, and that's over 3 million contact hours. This is a picture of one of our general sessions. I want to thank all of you for your support. So many of you listening tonight have been co-directors, faculty, sponsors, donors, and we couldn't have done it without your help. This is a picture of the health fair. You would not believe how incredibly interested people with diabetes want to learn about the devices and medications there to help them live a long and healthy life. And of course, there's the lunchtime. You wouldn't believe how much this lunch cost me. I'm a true believer that nothing can replace face-to-face contact. No app, no program online, no phone calls. I think that when people get together, they're in a place where they're the majority and not the minority. And they can talk to their brethren with diabetes and make some real connections. And I think that's so important and a secret to some of our success. Then COVID hit. And of course, we're all familiar with slides like this, for sure. And our staff meetings changed to Zoom meetings. And if I ever have another Zoom meeting, it'll be too soon. But it's a way to communicate and get things done in the COVID environment. So what's the silver lining? The silver lining is that we now can reach people around the world. And our new motto is TCOYD without borders. And we could reach not only other people in the exact city that we're putting on a conference, but that entire state, every state in the union, every country in the world. So I think that's the silver lining, that we will be able to touch more people. And I did say without borders, and that means type A, type alien diabetes. For some of you know me, if I don't put a goofy thing in like this, then I'm not Steve Edelman. Okay. I want to tell you about our plans to go virtual. And in literally 60 seconds, we have an incredible platform with 3D visualization where we can actually have live conferences with health fairs and networking set groups. And I just want to walk you through. You walk up to the convention center, then you go into a lobby and someone welcomes you. And you can either go to the auditorium, the info center, the exhibit hall, or networking lounge. The lecture rooms you can make any way you like. You can actually dress people. You can dress them up in suits and you can dress them down in shorts and flip-flops like Jeremy walks around. And you have an incredible health fair, different options. You can talk to exhibitors, you can get information, you can download information, you can watch videos, and you can give your information if you want to get called back or emailed later on. And of course, very important, the networking lounge. And that's trying to emulate the face-to-face conferences that we put on around the country. So we do have a prospectus. We just put this together. It'll be available online, and it will make sure that everyone that registered for today's program can get a copy, where it talks about all of our programs that we put on around the country, and now our virtual program. So in closing, these are the three main themes of TCOYD that we've had since 1995. You have the main responsibility of taking control of your diabetes. You are your own best advocate, and be smart and be persistent. And for some of you that heard Bill Polonsky give the Educator of the Year address, you heard him talk about the important things about patient education. You know, so important to educate, motivate, activate, and engage patients. And he had a special scale that I never heard of before, an official scale of boredom, which is one reason why many diabetes educations fail. And that's one thing that TCOYD does not have. And that's why we try to inject humor. And I'm a big believer that humor leads to information retention. So I want to give a special thanks to our partners, and a special shout out to diaTribe on the right over there, and to our TCOYD team that works quite tirelessly from our office right here in San Diego, where I'm at now. Michelle Feinstein to my left in blue, our executive director, took over for Sandy Bordette, who retired. And the newest member of our team is Jeremy in the upper left. He gives us a fraction of his week. He's pretty darn busy. So whatever time we can get from him, we appreciate. And lastly, to thank Kelly and the diaTribe group for making this all happen and working so closely all of these years. Okay, now, I think what we're gonna do is we are going to see if this video plays. And it's a video that Jeremy and I did kind of a spoof on Zoom calls. Hey, Jeremy. Can you believe it? We're in quarantine. It's March, getting used to Zoom meetings. How's it going with you? Hey, I can't hear you. Hit the mic button. There's probably a red line through it.
Okay. Is that good?
Yeah, I can hear you now.
Well, anyways.
Wait, I think you turned off your camera.
Oh.
Look for the camera thing and the line through it.
Is that better?
Yeah, I can see
you. See me now?
I can see you really good now.
Can you hear me? What if I speak into this? Is that better?
No, you can back up a little.
Can you hear me?
Jeremy, back up.
Yeah. Oh, okay.
Where are you?
Hey, I can see myself.
Where are you calling from?
Well, you know, quarantine hit. I kind of locked down a little bit. Got some supplies that I thought I might need. I don't know if you can tell. I got a bunch of toilet paper back there. I haven't pooped once yet, but when I do, I'm ready. And I got a whole big bag of chips. I got a couple of them.
You're hoarding, man. Don't worry.
Well, hey, if you need some, just let me know. But, how are you feeling about these Zoom meetings? This is our first Zoom meeting ever. I feel like this is kind of cool. You look great.
You know what? I want to dress the part. And then these Zoom meetings are important. But you know what's very cool? No one ever could see below your waist. And there was one day I could be in my pajamas all the way to 7 p.m. and it's comfy. In fact,
I'm dressed up, but I got sandals on for no reason. I don't know if you can tell that.
You don't have to wear your shoes.
So how's life treating you?
Well, you know what? I'd say overall it's been really good. Just thinking about being in quarantine and now things are changing at TCOYD, at least temporarily. The TCOYD, as you know, Jeremy, from the very beginning in 1995, we've been putting on face-to-face conferences around the country, over 200, last 25 years. I wanted to thank you also for joining the team in charge of our Type 1 track, our CME program, and working with all the great folks. But you know what? Things are changing, and we're going to switch to virtual, and we're going to still continue to educate and motivate people with diabetes and their loved ones, as well as healthcare professionals. So there is a silver lining in this whole, story.
Yeah, for sure. I think the number of people that we're going to be able to reach is really gone through the roof. Nothing takes the place of this in-person contact, but, going virtually, I think we're going to be able to get our great content out to just so many people. But I got to tell you, Steve, personally, this quarantine, the last couple of days, I feel like I have so much time on my hands. I don't know about you, just making food at home and talking to my mom and playing with the kids like all the time. So there's definitely been a lot of positive.
When people say to me, hey, do you have any time on Tuesday to meet? And I look at my schedule and I go, well, I got the whole day. What time do you want to meet? Normally it's like squeeze in, squeeze out. It's amazing. And I'm not that efficient at home, but it's just like nothing on the schedule.
I know. Quarantine is not bad. Well, hey, there's I took a little kind of YouTube class on Zoom, and you were mentioning the TCOYD website. So you can actually share your screen and show it to me. There's a little green button at the bottom of the screen. Just click that.
All right.
And then I think I'll be able to see your computer, so you can walk me through.
Yeah. Okay.
There we go.
Wait a second.
Well, Steve, what's that? What are you buying, bud?
Wait a second. My grandmother used my laptop. I'm not sure what she was looking at, but this is the man, that's scary. This is this is the TCOYD website. Cool. And this is where it all happens. And you can see all the different categories on top. And I think we're really doing our best just to get as much information out to people in a very interactive way, not just put on a recorded lecture, but to interact with people, to motivate them, to put diabetes high on their priority list. And also, we have a great section for healthcare professionals and where we could put on CME programs and let them know about the Diabetes Forum, which of course is happening.
Well, now that we're experts in technology and Zoom, I don't see any reason why we can't just own this space. And there's some more whips. I love that. Which one your grandma purchases and if she recommends.
You know what? I'll have to track that. Oh my God.
Well, hey bud, let's check in a couple weeks to see how things are going. But it's great seeing you.
Okay, I'm gonna learn how to use Zoom too.
Okay, love you, buddy. You're the best.
Love you too. Bye. We are 6 feet apart.
Travel restrictions are not going to stop completely when you have an outbreak. That is a true pandemic. But I think most health officials agree that at best it delays and, as the secretary says, kind of pauses things. The impact on the rest of the world is still a work in progress. We're dealing with clearly an emerging infectious disease that has now reached outbreak proportions and likely pandemic proportions. I know we'll be successful in putting this down now, but we really need to be prepared for another cycle. And what we're doing, I believe, will prepare us well.
Hey, bud.
Hey, Jeremy. How you doing?
Not great. It's been 3 months of this quarantine stuff. We're in June now. It's crazy, man. It's so easy to have just a case of the mopes. I love the mask. I don't know if that drinking style works, but I'm glad I'm talking to you, buddy, but I am so sick of Zoom. I don't know how you feel about it.
You know what? I'm sick of mass. Jesus. That was unscripted, by the way. Sick of mass. I'm sick of this stuff. Reminds me of KY jelly. And you know what? I am so busy. How about you?
Yeah, you know, and I will say, though, with the Zoom meetings, I've given up on trying to look nice. Just got this on. Sometimes I say my camera doesn't work, or I do the little crazy background so people have no idea where I am. What do you?
Check this out, man. I love Julian Edelman.
Yeah.
Patriots. There he is. And I still have my pajamas on.
Yeah, I love when you tell people you're related to him, which you're not. I don't know.
He's my second cousin. I'm living by. Hey, don't tell Jamie, my girlfriend, that I haven't washed these pajamas in 3 months.
Okay, will not tell her. Yeah, you know, like when we talked a while ago, I had all the time in the world. I was talking to my mom every day. Now it's all of a sudden I got Zoom meeting after Zoom meeting. Everybody figured out that I'm available. So.
Yeah, and you know what? They sort of forget that there's a weekend.
Yeah.
You're free every day. To me, Saturday is a Tuesday. Sunday is a Monday. And, you know, it is.
Day.
Jeremy, I've never been busier in my life.
It's crazy, you know, and then I was saying I had a less time for my kids and I was loving that. Now just like they're all over me, and I saw them this morning. They went outside. I haven't seen them since, but hopefully they come back. You know, I coined a new phrase at the VA. We always talk about PTSD from war. It's PZSD. I'm sick of Zoom. I want to go back to conference calls where you can do anything you want, walk around, and you don't have to, you know, make sure your nose hair is trimmed. Well, you know what I found that helps? Alcohol. And I have to say, I don't condone it, but I have been drinking a lot since quarantine started. I don't know about you. You know what? I'm really kind of irked at you because you introduced me to Pliny the Elder. I got mine right here. Not only is it a good IPA, it's hard to find. I spent a good hour searching around different liquor stores in the area. And if you're not a drinker, please don't start because of this video. Well, you know what? I'm tired of drinking alone, and quarantine. Things are starting to loosen up. Is there any way I could just come over there and have a beer with you? Sure. I think it's safe now. All right. I'm gonna get in my car. I'll be right there. Okay. All right, so show my new pet steak. I was actually just right out there, literally right there. I don't know if you could see me. You probably could see me. I was right there. A little bit, yeah. Well, good to see you, bud. Good. Cheers, man. We want to say thanks to everybody who attended the forum tonight. Thanks for all of the help everyone has done to make this thing happen. The TCOYD group, Kelly Close, and diaTribe, and all the folks that made this thing happen. And we hope you all enjoy the evening. Yeah. Cheers, my friend. Cheers. We're going to have each of our panelists give us their overarching view of the latest developments in diabetes, the highlights from the ADA. They're just going to do it briefly. Kelly and I are then going to ask each panelist in a particular order some high-level questions where they can get into some more details. And then starting the last 30 minutes, we're going to take questions from the audience. So we have Schaefer Bader, Jimmy McDermott, and Freedy Valconi, who are going to be looking at the questions as you type them in the Q&A section, so we can analyze them, organize them, collate them, and get a very efficient night in trying to answer all of your questions. Will, you want to go first?
Yeah, thank you, Steve. Thank you and Kelly for inviting me here tonight, even though it's virtual. My overall impression of the ADA, first and foremost, is I don't think we're going to go back to the normal face-to-face. I think that the way it worked out with being able to address and see all the symposia, I think there will be a balance to where perhaps in the future there'll be face-to-face, but I think the virtual symposia may be here to stay. And in fact, the format was such that it was hard to see everything at one time, but the beauty of it was you could see something live and go back and see the other later. My overall impression is just, once again, it's just been incredible, the advances we've made in the artificial pancreas. And I've been very intrigued by what's happening with the the advanced hybrid closed loop. It's also pretty fascinating that this language that in time and range and above range, which has only been there many years, is now common. And some of the endpoints that we now see are composite endpoints, such as what percent meets above range and less than 54. So the real advances in artificial pancreas was just phenomenal. I was intrigued by some of the new prevention data. I saw the DAPA heart failure prevention, and that was intriguing. And again, it wasn't the main aspect of study, but a 32% risk reduction in diabetes progression to me was pretty impressive. I think we got a lot of new information on where we stand with diabetes prevention, new data from the teplizumab trial, again, showing that the length of time to develop diagnosis now is 5 years as opposed to 2 years in the placebo. So that was very exciting. And new agents like blimipumab that also shows promise in new onset diabetes. And again, these studies showed preservation of C-peptide, which is important. So I actually felt that a lot of advances were made as far as understanding mechanisms and drugs and type 1 prevention. The other thing that was important, there was a lot on just heterogeneity of disease and understanding that it's not just type 1, type 2, and even within type 1 and type 2, it's just highly variable, individual and progression and variation. So trying to understand just the heterogeneity of the disease, I thought was fascinating. So those are my major takes. I'm sure that there'll be other things we need to talk about, but it's just pretty impressive, the depth of the science at the SCI sessions. But those were the few of the things that I wanted to highlight.
Well, those topics that you mentioned, we're going to be getting in more detail during the Q&A session. Vanita, I'm just going people next to my tile. I'm sure it's different for all of you. Why don't you go?
Thank you, Steve. Thank you, Kelly. What an honor. I'll just say what I really appreciated about the sessions this year is there was a lot of debate format. And so this ensured that we didn't just get a unidimensional view of any of the topics, but I think the session organizers made sure that we had the multiple aspects and multiple perspectives for the different topics. So I really appreciated that. The other thing, just by the meeting being virtual, I did miss that kind of learning by osmosis. And I'm saying this because, you know, Earl, Steve, Eugene, you know, Bob Henry, if he was still here, a lot of us younger folks learned from all of you guys just by osmosis, by seeing how you interact, how you dealt with the questions. Whether or not you knew our names, we learned from you. So I missed the in-person part. In terms of the topics, the big aha for me was, at times I didn't feel like I was in a diabetes meeting anymore. I felt like I was in a cardiology meeting, a liver meeting, a kidney meeting. And then it just occurred to me, you know, we're all in the same meeting. It was a full, whole patient meeting. And it was a true convergence of a lot of perspectives. I also really appreciated the discussions about hypoglycemia and hypoglycemia as a barrier to treatment, and finally it being recognized as such, and that the only way to treat hyperglycemia is by minimizing hypoglycemia. And yet at the very real tangible level, you know, it's easy to say CGM for everyone, but when you think about cost and when you have to think about where you spend your money, then it becomes a different issue. So diabetes is complicated, and I think the sessions did a really good job at presenting the different perspectives.
You know, Vanita, hypoglycemia has always been an issue, so it's nice we're getting back to the basics in some of these issues as well. Okay, Gene, why don't you go?
Well, first, Steve, Kelly, thank you for inviting me to participate in this, this forum, and also to you individually and collectively for the work that you do on behalf of all of our patients with diabetes. You know, we had our first ever TCOYD in Charlotte back in November, and you know, patients are still talking about that. It was really inspiring. I've had some conversations with people about when are we going to do that again. So
yeah, when are we going to do that again?
We can do it next week if you want. I think Vanita said it quite well. As a primary care physician coming to this meeting, I thought at first I'd stumbled into the American College of Cardiology meeting. There's so much going on about the cardiovascular effects of these drugs and just the whole cardio-renal metabolic system and putting that together. And it was really quite exciting because I have never really had the opportunity to think about this as all one connected system, even though you know intuitively that all the body is connected. So to see us now start to bring science and to that and really connect that is very, very exciting. With my background in undergraduate was in electrical engineering, and then I stumbled into some sessions. I thought I was in a technology meeting. We're talking about all of the kinds of things that we're doing with automated insulin delivery, algorithms, and CGM, and how we can actually improve the lives of patients by not only engaging them, but actually giving them control, empowering them in control of their diabetes. So from that aspect, I thought the technology was a highlight for me. And then finally, the thing that I thought was really kind of tied all this together is a couple of the sessions I went to really focused on patient-centeredness. How do we take what we know from the science, what we know from data? How do we take what we know from technology? How do we provide for the patient? How do we use this to leverage all of this knowledge and all this technology we have to help improve the patients? So those were my key takeaways from the meeting.
Yeah, thanks, Gene. You know, being a primary care physician, I mean, you guys see most of the patients with type 1 and type 2. So your presence on the panel is extremely important. Okay, Earl, please say your comments.
Well, first, Steve, I want to thank you and Kelly. I will behave myself, although we do have the distinction of having the only TCOYD that was snowed out last year. But we made up for it this year. Little did we know that just a few weeks after the TCOYD in Bellevue, Washington this year, that this pandemic would hit. And it has changed everything. You know, I agree with Will that I think that it will be really interesting 5-10 years from now to look at what the ADA looks like. One of the things that I really liked in the sessions were the chats. And I could see what other people were thinking and things that I wouldn't think about. And you could chat and watch the data as it was coming. And I found that absolutely fascinating because we could never do that in a real life meeting. But it wasn't only talking with people that I knew and I knew well, but I'm talking to people from all over the world. And I'll be very interested to see what the international attendance is, because just from what I could see from the chats, it just looked like we had more international attendees than we've ever had. So I thought that that was great. Other aspects that I really liked is the fact that I could go from room to room at the same time, where you could never do that in a live session. Absolutely not. Just the walk alone, even if you don't get stopped. And I really enjoyed that part of it. And I'm chatting in 2 different sessions with my friends about the data, and no one knows I'm doing 2 at the same time, which I am. And I thought that was great. Nobody has mentioned the posters yet. And the fact that I've had several questions for posters that I would ask the author, and I'd get emails back right away. And I thought that was great. As far as the information, there hasn't been anything that I really was all that surprised about, although obviously the automated insulin delivery session at the very beginning, I thought was just spectacular, looking at what's going on with the sensors and the pumps. A lot of information about the burden of the economics of this, and I'm particularly concerned about that, given what's happening with our economy in the US and around the world. It's a huge concern. I remember hearing somebody back in 1996, 97, after Humalog came out saying, we'll never get a faster insulin, we'll never get a slower insulin, and watching all of the different insulin, I mean, the once weekly insulin absolutely fascinates me, not only the clinical part of it, but the mechanistic part. The SGLT2 inhibitors, I mean, that should replace fluoride in the water when you go from talk to talk to talk. And I just guess you can't help but get excited when you see the secondary papers come out of the CVOTs. The one big negative that hit me today, I'll just mention, I went to the search trial for the kids, and I didn't realize we have more hospitalizations for ketoacidosis for newly onset type 1 diabetes in children and young adults. And that shouldn't be. We shouldn't be last. We should be first. And so, you know, when you go to meetings like this, you see the epidemiology of a lot of things. And there are things that come back that are, you know, frankly, not positive, and things that we need to work on. But overall, my final comment is there are negatives, like anything, of having a virtual meeting. And to me, it's the social interaction, it's seeing people, that's a big part of it. But it's also running into people that you don't know and making new acquaintances and coming up as you're having a coffee and coming up with a new study idea that you end up calling someone like Dr. Cefalu and say, we have this idea, what do you think? And this is where a lot of our ideas start when we all get together. And here we can't do that.
Yeah, thanks, Earl. Okay, Jeremy, you're gonna be the last batter, and then I'm gonna start off with the first question to you after that, and then Kelly's gonna jump in, and her and I are gonna go back and forth. Please.
Yeah, I just want to say, obviously, thanks, Steve and Kelly, for doing this. And sorry about the technical difficulties. I know both diaTribe and TCOYDs worked on these videos. Steve, I was excited to show ours, but I'm sure we'll put those online because we have a lot of fun making those. And I also want to give a shout out to Steve. I just interviewed him on 50 years of living with type 1 diabetes and, you know, kind of his story about what it's been like living 50 years. So that was a lot of fun. So I think, you know, honestly, when people ask me what stands out from this meeting, it's going to be that it's virtual and just the state of affairs that the world is in right now. I'm hoping Will's going to talk more about the state of research funding, which has been just a huge impact. So, you know, that really stands out. But, you know, on the positive side, I want to talk a little about what's going on in type 1 diabetes. And just the state of how rapidly things are changing is remarkable. So, Steve, I've been working with TCOYD for probably 10 years now. The last talk I always did at the end of the type 1 day was kind of what's on the horizon, what's coming in terms of the cure, what's latest and greatest. And for a while, I hated doing that talk because it was like, here's another trial that didn't work, and here's another thing that didn't work. And now here we are in these kind of, what I would consider these kind of 4 big buckets where everything is just going full speed ahead. So first is kind of artificial pancreas. And obviously that is on autopilot now. It's really taking off. And not only is it taking off, but I'm happy to hear kind of type 2 guys like Eugene saying that that's what stuck out to them. You know, and it wasn't that long ago that Steve, you know, people like you, me, and Earl were fighting for CGM being meaningful. And it kind of used to be fringe. It was like, oh, it's like an Apple Watch, you know, like it's just something cool with a gadget. And now it's here to stay. And there's no doubt about the clinical benefits of it. So I'm happy to see that bucket take off. 2 is adjunctive therapies in type 1 diabetes. I'll talk a lot more about that. I think that space is really interesting. I was excited to see a new glucose kinase activator and other kind of research in this space, pramlintide being used in different co-formulations. This area is near and dear to my heart, and I hope that, you know, I'll have a lot more to say about that. 3rd bucket is prevention. You know, we have anti-CD3 now, which might be approved hopefully, you know, earlier or later this year, where we might have something to actually offer people. It's just going to change public health entirely in terms of recommending screening kind of, you know, for people at risk or maybe the population at large. So that's going to be a huge change we see in the next year or 2. And then finally is kind of immunotherapies for people newly diagnosed. Some potentially positive results out of Novo Nordisk with liraglutide combined with IL-21. So in all these areas, we've seen kind of improvements. And it's really kind of hard to keep up with. So when I do this talk at TCOYD at the end of the day now, it's like rapid fire. Like, here's another cool thing. Here's another cool thing. Here's another positive thing. And that just was not the case a couple of years ago. So that's something that really stuck out to me.
Okay. Thank you, everybody. Okay, we're going to start the Q&A. I think, Jeremy, we're going to start with you, and it's a perfect follow-up. One of the things I know that it's near and dear to your heart are adjunctive therapies. And we have a long laundry list. Some of them have become a reality. So I'm just going to let you answer that question. What do you see currently on the horizon, and anything that's going to make a clinical impact?
Yeah, so this might be the question that I'm the most verbose on, so apologies in advance, and then I'll shut up a little bit. But I chaired a session on this topic, which was amazing. Nothing to do with me, but because the speakers did a great job.
reviewing the data on metformin, SGLT2 inhibitors, GLP-1s, and I'll give a really quick summary of that. Metformin, a large clinical trial now, the removal trial, has basically shown no benefit in type 1 diabetes in terms of cardiovascular risk reduction, A1C, so that's kind of out. GLP-1s are a really interesting topic for me. In type 1s, there's substantial weight loss, there's potentially improvements in hypertension, some mild A1C benefits. However, Novo Nordisk, who was the one that was kind of moving forward with this with Victoza, stopped that program because of a potential increased risk of ketosis. So we have this whole therapeutic class which might have benefit, but has no kind of way to go in terms of actually getting approval. SGLT2 inhibitors I could spend a long time on. This is controversial. It's now approved in Europe, Japan, just not approved here. I think that's a major loss to the US market. And then pramlintide is really interesting. Ironically, this was our first and only adjunctive therapy approved in the US. And I honestly think it hasn't had its day in the sun yet, but we're now working on co-formulations and potentially putting it in a pump. So long story short, as the dust has settled with all these programs, is that we don't have any therapy that we're giving to everybody with type 1 diabetes. We're certainly a long way from that. And, so at the end of the day, I think this adjunctive therapy space is at a crucial time. We've had some potential failures, and we need to stop back or take a step back and ask ourselves, what are we looking for an adjunctive therapy in type 1 diabetes? And I think we've gotten used to this type 2 paradigm where you add a medication, you look for A1C benefit, and we've tried to kind of cram these therapies into that round peg, if you will, and that's really kind of not the goal. So for me, an adjunctive therapy is something that's going to do what insulin cannot do, or a problem that insulin creates. So when I think about this space, I imagine in the future, if I'm on a closed loop system and my time in range is 95%, I have insulin doing its thing, and I'm great, glycemic control. I think I'm still left with a high risk of cardiovascular disease. I'm still left with issues with weight, obesity, being overweight, hypertension, DKA, all these types of things. So I think we need to realize that in type 1 diabetes, there's multiple metabolic disturbances. We know that glucagon is dysregulated. We know that amylin is missing. We know that there's profound insulin resistance. We know that there's glucose reabsorption issues by the kidney. So I would like to see us adapt more of a type 2 paradigm. When we see a patient with type 2 diabetes, we know about the ominous octet, and it's all about combination therapy. We would never see a type 2 patient and say, I'm going to treat every type 2 with just insulin, because we know about the benefits of addressing insulin resistance, of addressing, SGLT2 inhibition. And all these issues are present in type 1 diabetes. So what I would like to see moving forward is a realization that in this adjunctive therapy, we're never going to get an A1C reduction of 1%, 2%, that kind of thing. But we need to realize that there's still these issues, these absolutely well-defined metabolic pathways, that if we address these with specific targets, we can restore physiology, we can improve clinical outcomes. And I really think that we need to kind of further, pursue this space. I think that's very important.
Okay. Gosh, the program's over. You used all the time, Jeremy. Wil, you politely raised your finger. I know you're not a gastroenterologist, so what kind of question would you like?
Well, actually, again, Jeremy, I was at that session, and the data that Chantel presented on the SGLT2s was pretty impressive. And I think you make a very good point that perhaps we're looking for SGLT1s in type 1 and comparing it for what we already know in type 2. But when you look at the unmet needs, a lot of the boxes are checked. Okay, the main issue, and again, as far as the adverse event and doing the question and answer, I think you put it very nicely that basically, what is the answer and what are we looking for? Again, it's not an A1C change, but when you look at the reduction in insulin, or for that matter, the reduction in postprandial glucose or the weight change, those are significant. Now, the question is, again, she brought up a very good point that I'll ask maybe all the panelists. The issue of still for the genital infections and the DKA, which were 2 to 3-fold higher in the studies, and the concern would be, I guess, what happens in the real world. So how, even with the mitigation strategies, do you think that there is a way that we can address that? I'm sure through education, patient education, physician education, but I see that's the one thing that's perhaps holding this back. Again, she did mention what the criteria would be used in Europe, again, looking at individuals, lower dose for some of the agents and higher BMI and a certain insulin. But if you just look at it from the perspective of checking unmet needs, there's a lot of impressive data there.
Yeah, thanks, Will. I mean, I can just say briefly that I did watch the presentation from Chantel, and they do use it in a small percent of their patients. They're very cautious. As you mentioned, BMI over 27, lots of things that they recommend not to do, like go on ketogenic diet, things like that. And I did email Thomas Dana, who said that they were using it quite a bit in their clinics in Germany, but once COVID started, they really stopped because they were concerned about the added stress of that would cause DKA. So yeah, it's one of those areas where I think, Jeremy, you said it just right. You know, what can it do beyond insulin? Can it prevent something that insulin does and do a benefit that insulin can't do? Earl, I know you must have a couple comments on this.
Yeah, I do. I think, first of all, that if I look at what has received all the attention up until now has been the SGLT2 inhibitors after the 2 adjunct studies, simply because Novo decided, when looking at the A1C and the weight and the ketoacidosis, which was just in the one group, and the hypoglycemia, they decided not to pursue it. I actually think that from a public health point of view, the GLP-1 receptor agonists are a more important way to go for the type 1s and the type 2s. You don't have this big signal of DKA, you don't have the genital infections, you don't have all these other things. What you do have, though, however, it's more than just weight loss and A1C reduction. It's more than just stopping that spike from the food. There's a bigger issue here, and that is there was data presented in a poster, a mouse model, I believe, looking at what this does to the kidney, what GLP-1, and I think it was liraglutide actually, what it does to the kidney in general. And we know from all these CVOTs as secondary outcomes, we see these beneficial renal effects. What would happen if we had a GLP-1 receptor agonist that had an indication, an FDA indication for diabetic kidney disease in type 1 diabetes? The Pearl data was very disappointing. We all had hoped that allopurinol would be effective. Turned out it wasn't. I just think that after being an investigator in Pearl, and the A1Cs in that population was in the low 8%, and they don't always take their insulin. They don't really take really good care of their diabetes. Unfortunately, that's why so many of them develop the kidney disease in the first place. That's not a really good population to be starting an SGLT2 inhibitor. I think that the GLP-1 receptor agonists are a much more safer drug, and I just don't think we've given it enough attention in terms of, not just in terms of the metabolic issues, but in terms of the complications, and not to mention the macrovascular disease.
Yeah, that's interesting, Earl. It's an interesting take that I haven't heard from others. Okay, Jeremy has one last comment. I'm going to finally let Kelly take over the question and answer it.
The only thing I wanted to say was it's always been interesting to me that when you look at GLP-1s, SGLT2s, you get an A1C reduction 0.3, 0.4%, and that's always been described as measly or insignificant. You get a time and range increase of 10%. But when you look at some of these new artificial pancreas, developments, the latest and greatest, you get a, time and range improvement of 10%. You get an A1C reduction of 0.3, 0.4%, and that's heralded as the next greatest kind of advance. And I'm a big fan of all these things. It's just interesting to me the different lens we look at. If something is insulin-centric in type 1 diabetes, it's the way to go. If it's outside of that, it's rogue, it's weird. And I think that's an interesting kind of paradigm that we have.
Yeah, Jeremy coined the famous phrase, SGLT2s for type 1s are like artificial pancreas in a pill. Kelly, please, you've been so patient over there. The mic is yours.
Yeah, not at all. I just had one question back to Earl, and then I want to ask Gene a question about guidelines. But Earl, when you said that about GLP-1, what would your recommendations be on dosing? Because I think us as type 1s, we take insulin, and so it makes it a little more complicated with GLP.
So you're talking about dosing of the insulin?
Well, dosing of insulin and adding a GLP-1. That's interesting.
We've been doing it for years, although we don't do it as much now because it's much more difficult to get. We have a woman with type 1 diabetes with a BMI of 40, and she's been on it for a couple of months, and it's like her life has changed, and her insulin requirements have obviously come down. But you know what? All these, I remember when pramlintide came out, Similan, and how we reduced the prandial insulin by 50%, and everyone was so concerned about all the hypoglycemia. The reality is, at least for many of us, it's not everybody, it's actually become pretty easy no matter what because we have CGM to guide us. Yes, we'll reduce the insulin. It's somewhat arbitrary. You can't put into a cookbook. It all depends on the dose of the GLP-1 you're taking, how much you can tolerate, how much nausea you have, if any. But the CGM should be able to guide most people. Now, you're not going to do this the same way in a population. Our friend Ann Peters always talks about, she has these two populations. One, they're just trying to get access of insulin. The other, they have access to everything. But in the population that does have access, we take things down a little bit, but we let the CGM guide us is the bottom line.
So let me just make one final comment. And Earl brings up a good point. It's something we're not going to answer anytime soon, but the cardiovascular effects of these agents in type 1, if they exist, that would be an intriguing question. It'd take a long time to follow up. But again, the residual cardiovascular disease in type 1 is double compared to what we see for non-diabetic individuals, and the same for type 2. But it would be intriguing to have an agent that's as effective in type 1 against heart disease as we have in type 2.
And I think this is where we can learn from the type 2 CVOTs, where, it started off with the people with established cardiovascular disease, and could all of these mechanisms, blood pressure, weight, inflammation, glucose, could that have an effect on outcomes? But the fact is that 200,000 trial participants later, we don't have a single study looking at the same issue in type 1, I think is a big gap.
Yeah, where's Steve Nissen when you need him? Come on, he should be advocating cardiovascular outcome trials in type 1. Back to Kelly.
Huge gap.
Yeah, well, and we can talk more about that. I just want to say thank you to Rachel. There she's like, GLP-1, what is this? So I'm going to try my best, you guys. But thank you. And thank you to Crystal for trying to help answer that. But it's amazing to have, again, so many patients here. And so Jeremy talks a little bit about inflammation. You heard Steve talking about that before, and as inflammation, like we want to have less of it as type 1s. And so they're talking about GLP-1 is this other hormone that's produced in the small intestine, and it kind of it does a bunch of different things at once, which is amazing. I remember when I first learned about it, I couldn't believe the number of things that it does, right? So one is it stimulates insulin secretion. Another one is that it prompts satiety, meaning it makes us less hungry. It is making blood glucose more stable, and it gives less. The experience of taking GLP-1 is that people have less spikes, fewer spikes, and that could especially be very helpful for us as patients who are trying to get more time in range. And so those guys can tell me what are the other ones that I forgot to say, but it's kind of just about like stability, introducing more stability into kind of our lives. And the reason that they were talking about that was because it was pretty controversial a few years ago when one of the companies was trying to see if people with type 1 could be successful with GLP-1, because the cool thing is, and I'm so envious, everybody with type 2 here, us as patients, we're not used to taking drugs where we have fewer complications because we're taking this therapy. We're used to taking therapy to reduce our blood glucose, but not too low. And so that is really powerful. And all these people on all these people on the panel here, that's what they want to have for all of us. They want us to live longer, and they want us to be as healthy as possible. And and they're trying to figure it out. So I love that, and we might end up going back to that. But You know, Gene, I want to just go back to you. It's so cool. I agree with Earl, like going to the posters. It's amazing to go to the posters and to see how much you are there and how much you have mentored so many people and all of these different opportunities that you have given people. It's amazing to see. And spend some time if you're at the ADA in the exhibit hall, where you also get to see so many different things that are coming, and also in the poster hall. So what I wanted to ask you about was these guidelines and standards of care. It's kind of a black box to me as a patient, you know. The research happens and then all you guys get together, and guys and cool women and all you leaders get together and you're like, yeah, this is what's going to happen. We're going to change the standards of care. And we know that Wil made this happen all the time when he was there. There used to be a rule you could only do it once a year. And he was like, yeah, you know, we're going to do it all the time. But what's the impact of that? Gene, tell us about it, the impact on all of the doctors out there, especially primary care doctors.
Well, thank you for that question. And a couple of things I'll say about the guidelines. They are very, very helpful. And the abridged standards of care that the primary care advisory group has put together is very helpful, more readable for primary care. But they're helpful only to the extent that people, one, read them and use them. And as our therapies have expanded over the years, many of you who've been around long enough remember the 2009 therapies, we had 3 steps. And fortunately or unfortunately, many of my colleagues now in primary care are still on the 2009 guidelines. They have a 1, 2, 3 approach. Now, so they are following a guideline, they're just not on the most current guideline. And I think one of the things I think that we have the great opportunity to do is to make it easier for primary care clinicians, wherever they're practicing, to use the current guidelines. If you read through the paper print of this and you look at what I call the eye chart, it's 1, hard to remember. 2, it's very detailed. And if you're in the room trying to make a decision about where to go with a patient, that's not what you go to first. One of the things I think that the ADA did in the past year was absolutely brilliant was they put the Standards of Care app on a phone, an iPad, on the desktop, so that a busy clinician seeing patients who is aware of the guidelines, just not as aware as people who are using them every day, can in 30 seconds get to a good recommendation that's evidence-based, it's been safe, it's effective, and they can get to that. So I think we now have an opportunity, and I talk about this all the time when I give talks, to get people away from 2009, at least up to 2019, 2020. The other big selling point for that is that since it is a dynamic app, as new evidence comes out, new indications come out, you don't have to wait once a year to get the most current information and the most current recommendation. The one thing that I will say about the standards of care, and this is throw a little bit of a monkey wrench in that, is that they're still very glucose-centric. We're pushing people to move when the A1C is not at goal. From this meeting, we see that the A1C is not the only target that we have. So we need to be thinking more comprehensively about the cardio-renal metabolic system, looking at the kidneys, looking at the heart, looking at opportunities, and not just where the A1C is.
Yeah, I like that. I like that. And when I put a link out here so that people could hear this video where you're talking about it, one of the things I loved as a patient, you said, you know, make sure that you're checking in with your patients every 6 months to see, like, where are they? And do you think that's happening in the real world? And
well, it's happening more now than it did before because it's one of the quality measures that people get looked at for. I mean, we're still measuring A1C, we're measuring, with quarterly visits, we're measuring those things. What I'm surprised is, and I was just checking today, is that we're checking urine protein, but we're not checking urine albumin creatinine ratios regularly. So we have an opportunity through the app and through all forms to make sure that people are getting the right check when we're starting to look for early recognition of kidney disease, because we now have therapies that can make a difference.
Yeah, yeah. And that it's like kidney health is something we don't really think about. Many patients, I just speak for myself, we don't know to think about it because we don't learn about it. And I know that's what, so many different organizations are helping us do better. But do others want to jump in on this? I thought I saw a hand over there, Earl, and then Wil, please.
Yeah, just real quick to Gene's point. At least where I live in the Pacific Northwest, the payers are glucocentric. We have the CVOTs, we have the FDA labeling, but the payers still see this, for the most part, with little exception, as based on glucose. And so the payers are glucocentric while the rest of the diabetes world is moving on to cardiovascular and renal. And I'm not sure how we can change that.
I've got some ideas about how we do that. Is we get the patients engaged, involved through programs like TCOYD. Patients should demand to have their kidneys checked. Should demand to be checked for cardiovascular disease.
Well,
I'm going to comment to Earl first, and then I want to comment to Gene. So the reason with glucose-centric, Earl, is because we've been using the same biomarker to classify diabetes for 70 years, okay? And we know that diabetes, again, getting back to the heterogeneity of the disease, there are other factors. So that's an offline conversation. But Gene, one of the more important things that I think the standards of care, maybe, when this went unnoticed just a couple of years ago, was the fact that they put the patient at the center of the decision cycle for the standards of care. And that was something that was a huge move, as far as I can see, an acknowledgement that there needs to be shared decision making. So when you look at this decision cycle, you look at all these factors, whether it's cardiovascular disease, hypoglycemia, socioeconomic status, whatever, and then begin to make the decision on what's the right therapy. So despite all the great advances we've had with medications and now using these agents for cardio and renal protection, independent of A1C, that's fine. But again, I thought one of the most, the biggest steps the ADA took was acknowledging with this decision cycle for the standards of care that the patient should be at the center at the beginning before a decision is made.
Wil, I'll just mention briefly that a lot of people know that I'm really into this adherence with type 2 medication area, working with Bill Polonsky, administrative claim databases. And one of the biggest problems in type 2 diabetes is for people with type 2 diabetes to take their medications over the long term, adherence and persistence. And that's where shared decision-making helps to improve that. I know Vanita is dying to say something. Please, Vanita.
So I just want to echo what Eugene and Wil said in terms of the awareness of chronic kidney disease. And Kelly, you touched on this too. If you look at the literature and if you look, so many patients don't know what level they are at in terms of chronic kidney disease. And it could be none, but that's important to know. And just this last year, I actually started in my clinic notes to put the map, the heat map of chronic kidney disease staging, and I make sure that I go over that with every patient at every visit of where they're at, because now we actually have therapies that can make a difference. And you can't wait until the very end, stage 4 or what have you, to bring it up to the patient.
Okay.
I just want to jump in and say, just back to all of you. I mean, how do you see the roles of the cardiologists and the nephrologists? It was also not so much a diabetes meeting, not as much, because like you guys are saying, there's many more people here. But how do you welcome all of your friends from other specialties?
Why do they make so much more money than we do? That's the problem. I'll just say this, Kelly, that working at the VA and the university, it's unbelievable how many nephrologists are just prescribing SGLT2s like water. And cardiologists are using SGLT2s for heart failure and for cardiovascular risk reduction, GLP-1s. It's amazing that we are all brethren now taking care of our patients with type 2 diabetes. That's just my quick follow-up comment.
Why do you think they're doing that?
You know what? They follow the data. I mean, gosh, all the CVOT data, the credence and other data looking at cardio-renal protection. And they've gone through the list of their toolbox. And now they're looking for other things to help them. And I can tell you what, the VA, the formulary there, very lenient with SGLT2 inhibitors and GLP-1s, whereas in the past, they're way more glucose-centric. So I think by cardiologists, nephrologists ordering these medications, pushing the system along, I think it's going to open the door with other kind of payers as well, especially when they're convinced that in the long run, they're going to save a lot of money preventing heart attack, hospitalization for heart failure, things like that.
Well, I actually think this blurring of the disciplines is incredibly good for the patient. And what it's allowing us to do, getting back to Earl's point as far as glucose-centric, the diabetologist now is reaching out to macrovascular disease and educating the cardiologist, and we're learning a lot from the cardiologist, we're learning a lot from the nephrologist. And going back to this merging of disciplines, again, as Bob Eckel talked about in his presidential speech yesterday, he's been promoting this cardiometabolic training where individuals interested in diabetes will get trained in cardiology, and there'd be this almost this joint, not board certification, but a joint discipline. And I actually think this people with diabetes and providers who care for those with diabetes and reaching out and understanding the macrovascular disease with this discipline, I actually think is going to be very good.
Salary sharing, I like that. Earl, you had a comment.
Yeah, just a quick comment. My question, and Will, I agree with everything you say, but how many cardiologists do you know who gets a call from a patient wanting to know how to best treat her severe vaginal yeast infection because of the SGLT2 inhibitor prescribed by that cardiologist? It's an issue. I had a patient, it's been a couple months ago. He's an 80-year-old man, known heart disease, and his cardiologist prescribed him literally the day before an SGLT2 inhibitor. And that seems reasonable. One itsy bitsy problem, he has type 1 diabetes because the cardiologist didn't have the understanding. Not all diabetes is the same. And so while I agree in principle with everything everybody has said, we still need a lot of education if we are going to have cardiologists and nephrologists making these decisions on how to use these, when and how to use these drugs, especially if they're going to be doing the prescribing.
So
just a quick comment on that. I think one of the things in our area that we see, the cardiologists and to a certain extent the nephrologists tend to be more guideline driven. They follow guidelines much more closely than do primary care. So to that point, you know, the ADA and the American Heart Association and I guess the American College of Cardiology has started to talk and have some crosstalk about guidelines on the use of these new therapies, particularly GLP-1s, SGLT2s. I know the ASN is going to be having their meeting soon, and hopefully they will start to come in and echo some of these same recommendations. So my point in that is once all of these organizations are starting to sing off the same sheet of music, so to speak, I think you will have an opportunity to then have better care for the patients and perhaps even make your ways onto some formularies.
So Earl, I was, again, talking about, I don't expect cardiologists and nephrologists to take over primary care of the patient. That's not the point I'm making. The point I'm making is that understanding cardiovascular disease and learning from the cardiologist and nephrologist, I think that's very valuable for us. And it speaks to, once again, a discipline where you learn about diabetes and cardiovascular disease, I think in the long run would be very helpful. But you raise a good point. It's still not taking expecting a cardiology who comes from the cath lab to take over primary care of the patient.
Yeah, thank you, Will. All right, well, we're gonna go to the next question. Thank you for that great discussion. Super interesting. All right, Vanita, you know, there really seems to be more and more GLP-1 receptor agonists in development. As you know, we had BID, daily, several weekly, and now oral. And a lot of companies are studying the GLP-1s in higher doses for weight loss. Give us your thoughts on their place on the ADA ESD algorithm and their impact on type 2 diabetes now, and maybe a little bit in the future based on the current clinical studies.
Okay, great question. The GLP-1s have been really a great journey to be a part of, because I remember, Steve, when I was a fellow, I was part of the first GLP-1 study with you over there. And we've learned so much, you know, from first exenatide twice a day. Oh, this lowers postprandial glucoses. Well, then liraglutide came out. No, wait, it actually lowers fasting. And slowly with each new GLP-1 receptor agonist, we realized that no two were the same, that each covered a different aspect of diabetes. And fast forward, we had the once weekly GLP-1s, and then dulaglutide, exenatide once weekly, albiglutide, and then semaglutide, which kind of broke to the next generation of higher A1C reductions, higher weight loss reductions. And what I think we're starting to see is that when you put the patient in the center, we can't just focus on glucose alone. We have to look at the effect of weight, and minimizing exposure to high glucose and minimizing the harms of excess weight are both a good thing. And so now the next generation of GLP-1s that we're starting to see in phase 2 and phase 3 are starting to tackle that. Can we increase the amount of weight loss through a pharmacologic leveraging of the GLP-1 to do all the things that Kelly described, suppress appetite, and help regulate and restore more normal physiology. And so I think that's extremely exciting. In terms of where they are on the guidelines, Will pointed it out nicely. Just the previous iteration of the guidelines were what I call the dim sum menu. There were so many different options, all looking like they were equal on the playing field, and almost that grab bag toolbox. Well, by putting the patient in the middle and putting all the data around, you can actually match drug with patient, for the patient's issues, the comorbidities, short-term, long-term kidney, heart, weight, blood glucose, and start picking smartly the agents that would best match that condition. And the GLP-1 receptor agonists have a lot going for them in terms of cardiovascular protection in patients at risk, potential effects on the kidneys, probably the most effective glucose lowering reduction, even more than insulin in some of the studies. And so where we see them in the guidelines now is really matching to those strengths. So in the patient where weight is a concern or obesity is a concern, the GLP-1s are prioritized. Based on the head-to-head studies comparing GLP-1 receptor agonists versus insulin, given their comparable, if not greater, A1C reduction with weight loss and low risk of hypoglycemia, now they're prioritized prior to insulin. And then in patients with elevated risk of cardiovascular disease or with established heart disease, they're prioritized there. So history of heart attack or stroke, for example. So I think we're starting to see the more personalization.
Vanita, thank you. I wanted to ask you this brief question, and any of the group, including you, Kelly, obviously, you're an honorary endocrinologist, by the way, and a lot of companies go through a lot of hassle to get the FDA official approval of reducing cardiovascular disease. Now we're seeing reducing renal dysfunction over time. Do you think it's a class effect, the cardioprotection we see with GLP-1s?
So in terms of the data, when they've meta-analyzed it and put it together, there looks to be a class effect, but there are individual situations. For example, the Xendin, there's a thought that the Xendin base may not have the same effect, but it's one should appreciate that these trials have had different trial designs. And so in general, at least the GLP-1 related agonists, they do appear to have a class effect there.
Yeah, you're right. All CVOT trials are not created equal. So
yeah.
Anybody else want to comment on that? Okay, Kelly, you're up.
Yeah, my next question is for Will, and I wanted to ask you, so all this amazing research that you see, biomedical research advances, they're all about relying on basic and clinical and translational research. And, but with this global health crisis, with the pandemic, with social distancing, COVID-19, we know it must be disrupting research at many levels. And so I was wondering if you could tell us, how is COVID-19 affecting research projects at the national level, in diabetes national and international level?
Thanks, Kelly. Well, research around this country is not immune to the effects of COVID-19. And we know the disruption in everyone's lives, in retail, in research, in clinical. And basically, research in general has been affected. A lot of the research activities have been suspended or delayed, and they're directly related to the COVID virus. There are many issues involved. First of all, a lot of the studies that we're talking about today relied on the face-to-face interactions. And for now, during COVID, we see the clinics and universities closing, going virtual. Well, that has an effect on clinical research. A lot of the studies had to go to the virtual visits, but what does that mean to the research? You know, you rely on laboratories and procedures as markers of efficacy, but some of these studies now may miss some of this outcome data. So that's a problem with clinical. What to do about medications if people are on a study and they need to get the medications, and now it's a virtual visit. So a lot of the studies that were ongoing have been halted. A lot of the studies are not recruiting. Studies that were scheduled to start are delayed, and this is happening around the country. And the other thing we've noticed is that investigators may be part of a trial, but you know, they may be called to actually take care of patients. So it's affected everyone. And again, research is not immune, and that's part of the problem. The problem is going to be what happens when we come back or get to this new normal. Are patients going to be comfortable coming into clinic, or are they going to have to be tested for COVID-19? If we go to more virtual visits, are patients going to be comfortable with that technology? And even basic laboratories that don't take care of humans. Personnel to maintain animals may not be available. Critical animal models may have to be sacrificed. So there's a lot of disruption. The other issue is going to be the universities that have taken a financial hit during COVID. Are they going to have resources available to put toward pilot studies and to rebuild this infrastructure? And the other thing we worry about is what about young faculty that may have been promised a job or expected a job, and now with the layoffs and the furlough. So it's affecting a lot of research, but it's affected every level of our lives. I'm just hopeful that with the testing and we can come back, that the research will come back too. It's going to be so important that we get back to some semblance of normal.
Dr. Fauci, Cefalu, what's your general sense about how we're doing as a country with the COVID situation? I know it's different in different states, but I know no one here on the panel has a crystal ball, but it seems like things are moving sort of in the right direction.
Well, again, at the NIH, there's been a lot of activity toward working toward therapeutics and vaccine, and a lot now with trying to get diagnostic testing going at many different levels. So I think the focus at the NIH right now is that you know what Dr. Fauci and Dr. Collins is working on, a big activity with public-private partnerships with the NIH for therapeutics, for vaccines, and I think as far as diagnostics and testing is the focus at this time.
Okay, thank you very much. All right, we're going to go to Irl. And another kind of COVID-related question. There's a lot of clinicians on viewing us tonight. And besides all of the research you're involved with, Irl, because I know that you really got your hands on a lot of great stuff. Can you describe how COVID-19 has morphed your clinical care in the diabetes clinic at UW? You're one of the few people I know that do a tremendous amount of clinical research, yet you still see a lot of patients. And that's why you don't get any sleep either. You and Kelly don't get any sleep. Do you think it works well? What is missing compared to the live visits? What are you going to do when COVID is over? What are you going to continue doing? What are your thoughts on that?
Yeah. Well, first of all, to your first point, that's why when you text me at 11:30 at night, you usually get an answer, which happens pretty often.
Yep.
So just because of where I live in Washington State, if you recall, we had that huge burst of activity from that one nursing home. The whole state closed down. We were one of the first ones. And this move to telemedicine, which was supposed to take about 2 years, took about a week and a half. And we learned very fast. We learned how to do it from home. It was a very steep learning curve. But now, since our state continues to go down, unfortunately, the rest of the country is not right now, but we are slowly opening up. The county where I live and the county where University of Washington is, we are in phase 1.5. We're not quite at phase 2 yet. But what that means for us in the clinic, not on the research side, but on the clinical side, is that patients all have the option of doing telemedicine visits or face-to-face visits. And so the last couple of weeks, I've done several hybrid clinics, which are both telemedicine and face-to-face. And I can tell you there is 100% agreement among the clinicians in my clinic. Hybrids don't work well for this. It may be great for a car, but not for running the diabetes clinic. You can't go back and forth like this. And I think the way this is all going to evolve, because I think the telemedicine will stay with us, although there are a lot of issues that need to be worked out with it after COVID, is that we could see where certain visits for some providers are telemedicine visits and others are face-to-face, because combining them both from the clinician point of view, the medical assistant point of view, all the infrastructure in the clinic point of view, it is really, really difficult to do. And, you know, I like telemedicine. It's better than not seeing the patient, but on the other hand, I have to say, I much prefer the face-to-face. I like the social interaction, just like we were talking about earlier with the meeting. And there are issues even with the physical exam. The biggest thing for me as an adult endocrinologist who sees a lot of older patient, Medicare age patients, are accurate blood pressures. I can't get that. I don't get as good a look at the feet, the pump sites, if they're wearing a pump. I had a patient last week who had some changes in her vision, and we both decided we would send her to the eye clinic where they had appropriate PPE. We have these fabulous new ophthalmoscopes in our clinic. I'm not going to use it, and the patients don't want me to do that, and I'm fine with that. So things have changed. It will be interesting to see how this all evolves with where I live, state-to-state telemedicine. Some states it's allowed, some states it's not. And then the big issue is going to be what's going to happen with reimbursement. It's different in a standalone clinic than a hospital-based clinic like mine because of the facility fees, and only time will tell how the reimbursement part of this will work out.
Yeah, thanks, Earl. I mean, everyone has their own opinion. I'll get to you next, Gene and Jeremy. But at UCSD, they keep sending us emails. They're losing hundreds of millions of dollars, and they're trying to push us to go back to face-to-face visits in clinic. But I should say that diabetes is probably a perfect condition to do telemedicine, as long as they have a primary care doctor. I know, Jeremy, you had a comment, and I know, Gene, you can go next.
Yeah, I mean, my only comment is obviously there's pluses and minuses of the telehealth, and like you, Earl, we got it up and running overnight, which was actually kind of hats off to the universities and everything that was able to do that. And you hear that in any given day now, there's more virtual medicine visits than there were for the whole prior year, you know, before COVID. So this has changed overnight, and it's not going back. I do love, you know, when I'm seeing patients and it's like, you know, they're connecting and all of a sudden they show up, and, you know, one of my patients last week was just on the beach, you know, and then they're in their house or in their car, you know, so you get this insight into, you know, their living situation. So I like that it's easy for patients. They don't have to, you know, go through traffic. They don't have to wait in the waiting room, all that crap. Like Steve said, diabetes is the perfect, you know, kind of disease state for this. The downsides, I think, is that for me, it's a very isolating way to practice medicine. That instead of going out to the, you know, the clinic and saying, hey, I need to get this prior auth, and hey, can you train this person on whatever drug? It's all virtual. You know, can you schedule an appointment via email in 3 months, and can you do this? And like, so I think it puts a lot of onus on the provider to kind of be the central, you know, peg more than ever. And that's just a little bit different, a different way of practicing medicine. But I would say overall, I've enjoyed it. But there's no going back. It's always going to be a hybrid now of virtual and, you know, real time for diabetes.
Jeremy usually hugs all his patients, so he's really down about that. Gene, did you have a comment?
I did. And it goes back to something that Wil said earlier. And I want to bring this out because what we found is very similar to what Earl found and Jeremy, that the practitioners don't like it so much. The patients love it. And going back to what Wil said earlier, if we're going to practice from a primary care perspective in a patient-centered environment, we really need to move toward what the patients like. The other thing that you get to see with that is you get to see their living environment. As we start to talk about the social determinants of health in primary care, and that's part of our patient-centeredness. What better way than to see where they actually live? Look at their home conditions. When they come to the office, it's a little bit different than actually seeing where they are, how their house is set up. It's not the same as a one-on-one. And I suspect from primary care perspective, in the coming years, we'll have one face-to-face visit a year where we'll do the head-to-toe, find that, but the virtual visits will become very much a part of primary care.
Thanks, Gene. Well, for the rest of the panelists, we got less than 30 minutes left before the Q&A from the audience. Let's try to make our answers a little briefer, mainly because we have so many good questions to ask. Okay, Kelly.
Yeah. I just wanted to say, but thank you, Gene, for saying that about patients, because I think there's probably pretty creative things that can be done with payment models and all of that. And there's also, sometimes it's not traffic. Sometimes it's people have 3 jobs, or people have kids, parents they're taking care of, and all of that. So thank you guys for thinking about this as creatively as possible. I just wanted to go back, Jeremy, to ask you again, just say a little bit more about glucagon. That's an important hormone. People are talking about it more in type 1. Can you talk about its role, not only about how our glucose works, but also as type 1s, as we think about insulin resistance and inflammation, and then all of this new stuff out there about glucagon, what do you like and not like?
Yeah, I'll try to be as quick as possible, but glucagon is a really interesting hormone, obviously. And in type 1 diabetes, it's a duality of problems where we don't make enough when we're hypoglycemic, so we need to restore the ability to respond to hypoglycemia. And then type 1s, being a type 1 myself, we make too much after meals, so it contributes to hyperglycemia. So it's completely dysregulated. And I've done a lot of research on glucagon receptor antagonists as a way of blocking glucagon, reducing insulin requirements. And I believe that it's hyperinsulinemia. It's the high amounts of insulin that type 1s are exposed to from diagnosis that induces insulin resistance and can predispose to cardiovascular disease. So I'm really interested in this space, whether it's glucagon receptor antagonists or other therapies, to reduce the amount of insulin that type 1s take to potentially improve insulin sensitivity and cardiovascular disease. And we also had an abstract showing that when people were on glucagon receptor antagonists, just a small handful of type 1s, that we suspended insulin for 6 hours compared to not being on the drug. If somebody was on a glucagon receptor antagonist and had no insulin on board for 6 hours, they essentially made no ketones. Versus, when they were just on placebo, their ketones went through the roof. So I think this might be an interesting therapy that could potentially protect from DKA and maybe improve insulin sensitivity, reduce cardiovascular disease. And this goes back to my original comment on what we're looking for in adjunctive therapies, is it's these kind of outside of the box thinking of ways to improve cardiovascular disease and type 1 diabetes, reduce DKA, hypoglycemia, these other kind of things that we really need to think about. So that's on the high glucagon side. On the low glucagon side, in terms of restoring hypoglycemia, that's where the space has really exploded. And obviously we've had nasal glucagon now. We have Xeris that has a preloaded pen. They're supposed to launch a kind of an auto-loaded pen in July, kind of more like an EpiPen. Zealand is working along the same lines, and maybe a mini dose glucagon, which would be amazing. There's nothing worse than being a type 1 at the gym and having to sip a Coke when you're on the treadmill. It just is ridiculous. So having, a little kind of, you can dial up a unit or 2 of glucagon is something that would be amazing. And then of course in the bionic pancreas, so we fully enrolled, despite COVID being in place, and Irl, your site there also, we were able to fully enroll virtually for the first arm of the bionic pancreas study, which is going to be insulin only. And it's supposed to start in August, even though we fully enrolled everybody. And then after we do the insulin only arm, we're going to add the Zealand glucagon component to see what the effect is adding insulin and glucagon to the bionic pancreas. So there's a ton going on in the glucagon space, blocking glucagon, glucagon agonists for obesity and type 2 diabetes, glucagon for hypoglycemia rescue. So it's kind of the golden age of glucagon, if you ask me.
Yeah, and so as patients, we should never, ever be in the hospital for severe hypoglycemia, and we should never, ever be in the hospital for DKA, right?
I mean, and I want to emphasize what you said about rescue glucagon. I mean, between the Xeris device and the Lilly nasal glucagon, it's so much better than it was before when you had to mix everything up. So I think we've come a long way since the archaic days of mixing desiccated glucagon in a diluting fluid. Okay, I'm gonna go to the next question. I'm gonna ask it very quickly, and I think everyone on the panel probably has some comments to say. Gene, you know, there's been more and more data. I'm super impressed at this conference, the ADA, how much there is on CGM and type 2s. And I have my own opinion on that. I'm going to hold that for now. But being a primary care doctor, based on what you've seen from the Onduo studies, several others, what is your opinion on that? Do you think it's going to make a change? Do you think we can implement it? You know, if it's cost effective, I should say.
I'm going to be brief. Yes, I think it will make a change. Yes, I think it has a great potential, not just to help in their A1C time in range, but for patient engagement. It is a much more empowering tool to have patients can understand how to make changes in their time in range a lot easier than they can understand how to make a change in their A1C. And just seeing that and seeing their eyes light up when they see what they eat, what it does, and what they do, how that affects it, makes a big change for them.
They understand time and range better than the FDA. I was at that sotagliflozin AdCom meeting. Oh my God. Any other comments? Earl.
Yeah, Steve, Rich Bergenstahl presented that amazing data with the Libres with 1,200 basal bolus patients showing a split of the curves of either going to the hospital or the emergency room for a hypo or hyperglycemia emergency. I mean, once the economic data comes through on that, that's, I think, to your point and to Gene's point, but it happens right away. You know, these aren't patients who are all going to academic medical centers. They were not in a clinical trial. It was one of those real world experience analyses. And I just think as we see more and more of these, the cost saving of putting populations of type 2 diabetes on CGM is going to become more and more clear.
Yeah, I think the key is engaging patients to look at the numbers and see what happens when they take their medications, when they don't take the medications, when they exercise, when they don't, when they eat, you know, certain portion-sized meals, and when they eat more than they should. I mean, it's amazing. You can't just slap it on them, but it has to come with some instruction. Vanita, do you have any comment on that? I know you do. You're so polite and quiet. Remember, raise your finger like this, like a gastroenterologist, and I'll call
No,
it.
I think the points are well covered. I mean, it's going to be about cost, but when it comes to insulin management, the quicker patients can be part of that loop in terms of self-management, self-titration, self-adjustment. The studies are out that patients self-titrate better than physicians do. So I think CGM is that important tool to empower that knowledge of self-management.
Yeah, I love that. I just wanted to jump in really fast on Vanita and just say, you know, it was also amazing to see Tracy Brown at ADA advocating, you know, to take those barriers down and to make it easier to get CGM. And right now, you know, it's much easier if you're on CMS, if you're on Medicare, talk to your doctor, talk to your healthcare team to try to get it. I know it's not simple, but that was a big deal. And I know that a lot of you have worked on that advocacy, and it is really worth it. Sometimes I think doctors don't necessarily know how much has improved in CGM, and we want to make sure that we can get it for everybody who can use it. And for many, knowing about professional CGM is also so valuable.
For all the viewers here, I want you to remember this meeting because, you know, now CGM is the standard of care for type 1. Some days it can be the standard of care of type 2. You know, how easy can you put it on? How inexpensive it could be? And I do think it could be tremendous cost savings, Kelly, as you mentioned. Okay, back to you, Kelly.
Yeah, I wanted to also ask Vanita about liver disease. We're just hearing a little more as patients, NASH, NAFLD. What is that? What do you think about it? There were 3 phase 3 trials last year. I don't think they all went that well, but tell us what you think.
Yeah, I think this also goes in that same picture of the cardiometabolic condition and the cardiometabolic patient. And I like to look at it as if you take a step back, each of our end organs, the kidney, the heart, and the liver, they have a window to the metabolic milieu, the metabolic environment. And when glucose is high, that triggers a cascade of other local processes. And then at the organ level, when it becomes advanced, you start getting organ damage and fibrosis. And so we actually see common themes with each of the organs, and that is with the liver. And this came out in one of the posters when they screened over 500 patients with type 2 diabetes who didn't know that they had any history of liver disease at all. They had no known history of liver disease. A quarter of them actually turned out to have more advanced liver disease. So it's there, we're not picking it up. And glycemic control is also correlated with how advanced that liver disease is. And the other exciting thing is now that we're learning more about it, there are more targets and more possible interventions, and we're starting to see some positive data. There was some data with GLP-1 receptor agonists and with SGLT2 inhibitors suggesting improvements in the non-alcoholic steatohepatitis. So early phases in terms of treatment, but multiple potential targets. And I think it's something to keep an eye out for because like the other conditions, obesity is a big driver of liver disease and non-alcoholic fatty liver disease. And one of the speakers said that in the next 15 years, the occurrence of non-alcoholic steatohepatitis is going to more than double. And the primary driver of that is obesity.
Yeah. You're all about obesity prevention and liver disease prevention. I hope all of us as patients can hear how they're all talking. It's really cool. Back to you, Steve.
Yeah, I was just going to add quickly that I've been hearing about NASH, all these companies coming up with products for NASH, and it just boils down to, losing weight. And I'm still waiting for a specific therapy. We know there's TZDs have made an impact on NASH. Will, briefly, do you see anything at the NIH level on NASH? Seems like everybody's been talking about NASH.
Well, it gets back to, once again, there's a lot of studies and new agents that are being explored for NASH. But to Vanita's point, if we can attack the obesity and the weight loss, I think that's going to be key. I mean, it's tied into the metabolic syndrome. So I think that's going to be very important that we come up with effective ways to manage obesity over the long term.
Yeah, speaking about that, let's go on to the next official question. We've heard a lot about reversing diabetes and putting individuals with diabetes in remission. And there's a lot of marketing scams out there too. You wouldn't believe the number of people saying they can reverse and prevent diabetes. What does that mean? What does remission mean to someone at the NIH?
Well, let's talk about what remission means to anybody, a patient or a physician. And actually, if we go back to 2009 at the ADA meeting, we were asked, there was an expert panel there with endocrinologists, metabolic surgeons, oncologists, in fact, it was titled, How Do We Define Cure of Diabetes? And we didn't even think that remission could be possible on a grand scheme. And at that time, we were just struggling with the terminology. Is it cure? Is it reversal? Is it remission? Well, it's not a cure, because knowing that if you take metabolic parameters that are abnormal and put them into the normal range, and let's say a patient lost weight, well, if they have weight regained, this will come back. So clearly it's remission. But how long do you have to be in normal parameters to say someone has remission? Is it 6 months? Is it a year? And remission has to be agnostic of any modality, whether you got there with bariatric surgery or lifestyle. So restoring glucose into the normal range, at that time we thought if it was less than 5.7, less than 100, it'd be a complete remission, and partial remission was getting under 6.5. Well, over the last 10 years with metabolic surgery and showing dramatic decreases in weight, we know now that you can get over many years, 30, 40, 50, 60% remission rates where people have normal glucose control. The issue now is, metabolic surgery, is that for everyone? And so I was really impressed with Roy Taylor's work over the last couple of years, and he presented it about the DIRECT trial, looking at very low calorie diets and showed once and for all that basically remission depends on sustained weight loss. And again, about a 20-pound weight loss over 2 years, you can get 50 to 60% remission. The question is now, how do we compare all these studies? So the consensus thought now on definition remission is very simply less than 6.5 of all medications and at least for 6 months. So there's a lot of mechanisms involved as far as why a person goes into remission, but the major parameters are sustained weight loss, duration of diabetes, which is very important, and beta cell function. And those are really the predictors of who's going to go in remission.
Yeah, well, duration of diabetes, beta cell function are somewhat related as well. That seems pretty simple, Earl. I mean, Will. I mean, you know, it comes down to basics again. So, okay, Kelly, I'm going to let you ask Earl the next question, which I think is has been a super huge topic at this year's meetings.
Yeah, super huge. And I was just looking for Roy Taylor's new book, but I agree. A lot of people have been really spellbound by watching him here. So Earl, we want to ask you about AID, automated insulin delivery, so many different closed loop systems, hybrid closed loop systems, 670G, Control IQ, looping. Tell us about how it's changed your practice. Are people doing better? Does it change the potential for complications down the road in your expert view? How can, I think, and what we all want to know is like, how can they be integrated and used broadly?
Well, this is a 60-minute discussion, and so I'll try to keep it very quick. Excuse me. I think the main thing, Kelly, that we have seen both in our trials and in what we've seen with even the 670G up until now, is the people who really struggled with their type 1 diabetes, A1Cs, 8, 8.5, 9, 9.5, they come down. And we're getting these people who are at the highest risk, we bring them down so their risk isn't zero, but they're much lower risk. And we see that over and over. And as the systems evolve and get better, it's easier for everybody involved, including the clinicians, because the systems are getting easier for the patients. And so if we just look at this from an airplane for a moment, I think that these over time will be shown to be extremely cost effective because it's a lot of hardware. When you look at the cost of all of this, I think the big challenge right now is, we have 2 commercial AIDs on the market. By early next year, we will have 3. And if Beta Bionics comes out later next year, we're going to have 4 separate AIDs on the market. And you can say, well, that's good because there's choice. But there's a lot of behind the scenes work from the clinicians who have to learn each one differently. The downloads are all different. The training for the patients, even though we're learning how to do things virtually now. And I'm actually I'm concerned both about the patient side of it and the clinician side of it. And my last comment about that is, a year ago, I participated in the Endocrine Fellows Pre-Endocrine Society, their symposium we do for the Endocrine Fellows wanting to learn more about type 1 diabetes, 30 pediatric fellows, 60 adult internal medicine trained fellows, all going out into practice. And they all told me the same thing, the 60 internal medicine fellows, and that is they go out into the private practices, and this was March of 2019, nobody was doing downloading of glucose meters, forgetting pumps and sensors, just glucose meters. So I am hopeful that this telemedicine has sort of fast forwarded that and make it so that everybody is looking at everybody's data, and that's going to have a beneficial effect on AID, at least with my glass half full. That's what I hope happens.
Yeah, I see Jeremy wants to jump in there. I just want to say, you guys, if out there, the patients, if your doctor or healthcare team isn't asking you for numbers, you can do this. If you do BGM, if you're lucky to have CGM, you can do it. And I agree, that telehealth piece, but you deserve this as a patient to be looking at this with your doctor, right, Jeremy?
Yeah, you know, my comment that I was going to make is that I've always pushed continuous glucose monitors, and I've never really pushed pumps up until recently. And I think particularly with the development of Control IQ and hopefully, you know, newer systems, that we're across that threshold now where you have systems that simply can do things that you can't do, with MDI. So I've started to really, recommend these for patients, and I've been really blown away by, people coming back into the clinic and, the improvements they've had in time and range and things like that. And then we end up having conversations about, more sophisticated things about, exercise or alcohol or whatever it might be. So it's been, really fascinating to watch this development. And I've been really happy to see that this is really translated to something that I think is moving the needle in terms of getting people on these devices, getting, improved outcomes. And the last thing I was going to say is I've started showing people my tracings, which I had never done before because I felt it was braggy, like, oh, you're an endocrinologist, like, I could never do what you do. And now I tell them, especially overnight, this has nothing to do with me being a doctor or smart or good at diabetes. This is a system that is just taking control overnight. I don't have lows. I wake up at 100 every night, and you can do it too because I'm sleeping and you can sleep too. And I think, that's a powerful message.
Yeah, and just quickly, others out there, smart pens, other ways that you think about automation, comments. The chat is exploding.
You know what? Let me make a quick comment too. I cannot believe I've taken so many patients that I've been really trying to get under better control for years. And I always fault myself for being kind of too nice with people. And all I have to do is talk them to go on to either Looping, Control IQ, or any other system out there that where the pump makes the decision for for them using the algorithm. And I cannot tell you how many people have gone from upper 7s, low 8s, even 9s, down to below 7. And I do think that you can make a case that a lot of things you can get with these hybrid closed loop systems that we've been pushing for with adjunctive therapies, at least some of those. I know that Kelly, myself, and Jeremy have been using these hybrid closed loop. Earl is still on bamboo needle injections, but I do think the smart pens is a great alternative to help people. The InPen, without any product placement or anything, they suck in the CGM data, they help patients. And we have to remember that at least currently 75% of type 1s are on multiple daily injections. And then you start looking around the world and pump usage is quite low due to access problems. So I think things have changed. I'm like Jeremy, I never really pushed pump therapy. It's a patient choice. But now that these algorithms help make decisions on modulating basal rates, mini boluses every hour, the new Medtronic 780G, I mean, it's pretty impressive. We're gonna, Jeremy and I are gonna go into, go work at Starbucks because our patients aren't gonna need us anymore. Seriously.
What about the one with 2 hormones? Because Jeremy, you were talking about glucagon before.
Yeah, I think, we'll see what the clinical trials show. And, I have no doubt that there'll be, there was actually an abstract where they did, just in 10 patients, kind of a little crossover study with insulin and glucagon. And the average blood sugar with glucagon added was about 10 milligrams per deciliter lower. They had, equivalent, if maybe not a little bit less, hypoglycemia. So we'll see what the, the larger clinical trials show. And we'll have to decide as a community, what is it worth? If you add another hormone, another cost, changing infusion sets in terms of what you're looking for in terms of improvements in time and range and things like that. So, but I'm all for another choice. So let's get that data and decide, if that's an option that we want to give people.
Yeah, and I just want you guys to all know, like, what you have the power to do to help people. I mean, we're just looking. Gary is saying, I'm holding at 93% time and range over 90 days since the start of the year. Ron is out here saying, I went from 10 plus A1C to a consistent 5.7. You guys are amazing. And so you guys being so awesome about technology and how to bring it in your practices and all of that, and you helping the systems be smarter and saying what should happen there. But Steve, back over to you.
Yeah, Earl, you had a quick comment.
Well, I was just going to say that I want to make sure that the smart pens, we have one on the market now, we're going to have more coming out, and that's been transformational, especially with the with the telemedicine visits. I mean, we could never know what people were really doing with MDI, and now we can really see it. And related to that, which will also be in the Beta Bionics, and we're seeing this now with our current smart pen, is the fact that you don't even have to carb count. You can do meal estimation, and you do fine. And not only that, but eventually with these AIDs, I'm not sure you're going to really have to bolus. Maybe bolusing will be a nice thing to do, but if we really do get these faster insulins, these things are getting so smart that you see people doing well without bolusing because the automated pump brings it down. It's very cool.
Yeah, and you just minimize your excessive carb intake. Your thinking and calculations really go away, and your time in range may go up to upper 80, low 90%. So I think it's a tremendous time for people with type 1 because this stuff is here and now. So that's awesome.
I have another question for Gene, but I wanted to say, Steve, I'm in like 90s. I mean, that's not going to be me. But what is really, really cool is that when you don't have hypoglycemia, so you're like this, all of the hyperglycemia, it's not actually that diabetes is so complex. It's like, that's your choice. That's your choice of food. And so, you know, living with that, I think I've been able to learn so much. I'm so grateful for those systems. But Gene, I want to go back to this cool No Diabetes by Heart, this initiative that ADA has on kind of care and treatment in primary care. Can you say a little bit about that and what you want to make happen there?
Just say something very briefly about it. The American Heart Association and the American Diabetes Association, under the leadership of Wil and Eduardo Sanchez, put together an initiative to educate and empower patients and people living with diabetes and their practitioners about the awareness of the link between diabetes and cardiovascular disease, and also to the treatments that are available. I mean, it's a multi-pronged approach. Many of you may have seen some of the national TV ads with Angela Bassett. There are programs going on. There's sponsorship of pilot programs really to get the message out, not just to patients, but also to practitioners, and to make that connection in a very meaningful way. Wil, did you have anything else you wanted to add to that? You were very much a part of getting that started.
No, you said it nicely, Gene. Basically, at this point, it's heightened awareness, particularly at the primary care level. Those are the individuals who are seeing the patients, and to provide education so they know how to treat and recognize cardiovascular disease. And again, it's important that the primary care is educated and the patient is educated. That's the important thing for No Diabetes by Heart too. There's a huge patient education.
Yeah, thanks, Wil. Well, we want to stay on schedule. It is, well, for me, it's 6 o'clock, but it's the top of the hour. We have Schaefer Bader, a endocrinologist from UCSD that trained under Jeremy and myself. We have Jimmy McDermott, who trained under Kelly, going to medical school at UCLA. And we have Friedi Valconi, also going to medical school next year. They've been scouring the Q&A chat box. And I believe we're going to hear them, and they're going to come on and start asking the panel questions that have been coming from the people typing in. So we want to make sure we get to as many questions as possible. So try to keep your answers brief. Schaefer, you want to give the first question?
Yeah, great. Thanks, Steve. So just to start off, we've had a lot of great questions coming in, both on the Q&A and on the comments, a ton of them. So we're definitely not going to be able to get to everything. We've done our best to sort of summarize some of these questions and pick out ones that we think will be relevant to a lot of people. So with that in mind, you know, this first question actually follows closely on this topic that we were just discussing, No Diabetes by Heart. And this question comes really from the viewpoint of a patient. It comes from Laura, who says, as a patient, what questions should we be asking of our primary healthcare providers, and I think also our endocrinologists, to help ensure that our cardio-renal metabolic health is being looked after and assessed? So these are concerns that people have about their kidney health, their heart health, and how do they approach that discussion with their providers?
I'll take a first shot at that. I think part of the awareness program of No Diabetes by Heart is to script some of those questions. So what is my risk for cardiovascular disease? I have diabetes, I've had it how long, here are my risk factors. Let's have a conversation about what's my risk. What other complications of diabetes might I be at risk for, and what can I do about them besides just lowering my A1C? Those are great conversation starters. There are a ton of resources on the website if you go to nodiabetesbyheart.org that are both for patients and for practitioners to facilitate those conversations.
Yeah, I just say education is power. Just by the fact that you're asking this question to the panel is awesome. DiaTribe has an incredible library of patient-oriented articles about this, and TCOYD will join in there as well. So just by the fact you're on this program, the forum, it's impressive. Will.
Yeah, I just wanted to follow up what Gene said, but remember that the patient should ask, this is one of the really many questions in the decision cycle. Once the provider and the patient have this interaction, assessment of cardiovascular disease is at the top of the list, along with hypoglycemia, other comorbidities. So these are the questions that go in to really design an individualized therapy. So that's very important. And if the patient doesn't ask, they need to be educated to ask, because to Gene's point, as far as educating primary care physician, these are the questions that need to be held at the first visit with the patient to start this decision as far as ultimate medication or therapy.
And caregivers need to ask patients what are they concerned about too. Schaefer, what's the next question?
So this is a question that comes from Evelyn, and she asked that we discuss the psychosocial impact of these increasingly complex medication regimens with multiple adjunctive therapies, and this increased use of technology that really we see in both type 1 and type 2 diabetes, and how this sort of may affect the psychosocial health of our patients, and even the providers being overwhelmed with this sort of flood of options and information. It's a good question.
Vanita, you're the sweetest person on this panel. I'm going to let you go first.
Oh, I think that's definitely an important question, because we know that diabetes is a chronic care disease, and it's associated with a lot of stressors in terms of self-managing chronic disease. And one of the big issues is polypharmacy. And so for someone with diabetes, there's blood pressure control, which might take 2 medicines. There's cholesterol control, there's blood glucose control, and it can be overwhelming. But I think what we're seeing in this the last few years of the newer medications and everything that's available is one can step back, look at the totality of the regimen, and make smart simplifications. So it's not really about just adding one on top of the other on top of the other. In terms of the technology, I would say that it's important to understand what the technology is there for. So if the technology is there and it's not being used, it's not being engaged in, then that's just an added stressor. So simplify one's life, look at it smartly, and have the dialogue with your care provider, because you're not doing these measures for them, you're doing it for yourself.
Yeah, I think dialogue and communication. Yes, Gene.
I was going to say a quick follow-up on that. There are a number of programs, opportunities now for patients and their providers to take advantage of health coaches, people that will help them through this. So after the office visit, there will be some follow-up, helping them manage some of these complex regimens and really make more sense out of it. Let's face it, as we've all said, managing diabetes can be hard for some patients, and they may need a little more than we as primary care clinicians can offer them. So there are opportunities to use other resources that we have to help fill in that gap.
I'll just add, it's really rewarding, because now when I'm seeing patients, we can actually take away some of the medicines, because again, other technology and other medicines have been able to advance us there.
Schaefer, please.
Dr. Wright, in follow-up of your comment, taking advantage of some of these other specialists, other types of folks who know all about diabetes educators, nutritionists, dietitians, people like this, it seems that these folks are probably underutilized, and Jack had a comment on that and sort of asked, how can we get this information out to patients? How can we make people aware that these resources are there? And I'd like to add to that comment, will we have an opportunity with telemedicine to sort of, spread the knowledge of these types of folks to people who maybe didn't previously have access?
Absolutely. I know others will have opinions on this as well, but I think one of the things that we're seeing with this COVID, and we're transitioning our care models to virtual visits. Diabetes education now can be set up virtually. All types of resources that we have not really utilized fully in the past, we now have access to. And I think, again, meeting the patient in their home with the diabetes educator virtually, meeting the patient in their home, perhaps even with the endocrinologist visits in between visits, can be very, very helpful and reassuring to the patient.
Earl, do you have any comments on that? I know your UW clinic is pretty impressive these days, utilizing other healthcare specialists to help coordinate care and education for the patients.
Yeah, the COVID pandemic has really changed things, especially with our psychologists and psychiatrists. We're very fortunate that we have both. And I don't know how we could do it without. There are not always resources in the community. There are, but they're hard to find. And for us, it's a very easy thing. But I just want to point out that with everything that's happened over the last few months, we have become more dependent. It's really become sort of survival. And it's like everything. People who were sort of on the edge before, this has really drove them the wrong way. And we see it in their glucose control. And what's really interesting, just from a diabetes point of view, I can see it because I can see it in their blood sugars. When somebody really falls off, I can see it. I'm seeing really two different types of situations right now. I'm seeing one where somebody is exercising every day, they're more careful with what they're eating, their time and ranges are going up, their A1Cs are going down, or I see just the opposite. And the ones who are the opposite, I may talk almost nothing about the diabetes, the hypertension, the adherence, and it turns into a complete mental health visit with myself, which is fine, and then the need to refer them to somebody who's more expert than me.
I refer all my patients like that to Bill Polanski, because no matter where they are in the country, they could just get them right on the internet. And it's such an important issue, and Bill has always made such a huge contribution to this area as well. Okay, Schaefer, please.
Okay, this question comes from Divya, who brings up the point that all of these changes that are going on in diabetes, the advancements in our field, which are almost impossible to keep up with, and that it's really a question about medical training. That in medical school, there's only so much time to talk about diabetes, and people coming out of medical school and subsequently in their residencies, et cetera, may have a limited exposure to this. So the question is, for those who are involved in medical education and training medical students, residents, and other healthcare professionals of different types, how can we actually improve the curriculum to help them understand and sort of approach diabetes care in a better way, especially, again, knowing that many of these folks, for example, end up being primary care physicians that have so many things to juggle?
Vanita, why don't you go first? You did your fellowship at UCSD, and you hung around medical students. I've heard Earl rant about medical students getting like 2 minutes of diabetes education during their 4 years. I remember that 2%. What do you think about that question?
I'll tell you that the standards of care have actually made a huge difference in making sure that we have a more standardized approach to what we're educating and teaching the new trainees on. And what we've done at the Brigham is we've created a standardized teaching slide set that we update every year in line with the standards. So we're all saying the same message. And each of the faculty rotate utilizing the same exact slide set, same exact curriculum for all the incoming interns. And then we continue the dialogue after through other opportunities. But we make sure that everyone gets the most current education. And the medical students and the trainees, they're smart. They're on top of it, and they ask all the right questions. So we're not recycling stuff from 20 years ago. We're staying on very in line with the current standards.
So toward that goal, again, I think we could also argue that as far as nutrition, that we're not adequately trained in medical school. So it's, diabetes, nutrition, and other aspects, but to try to get primary care trained in addition to, trying to, once they're in practice, give them guidance. Gene, I know that there's been some interest in having primary care take a year to be certified in diabetes. Do you know where those programs stand now? Because that would be an individual who's trained in primary care, but yet gets special certification in diabetes. Where do those programs stand now?
Well, that's great. We have one at the Duke Southern Regional AHEC that we've had for actually several years now. These programs started actually through a CDC grant, I believe, with Dr. Robert Tannenberg up at East Carolina University. There are several programs, I think, throughout the country. Jay Shubrook has one on the West Coast. And these are typically trainees who completed 3 years of family medicine or internal medicine, and they go on to do an additional year of just diabetes training, where they train with endocrine fellows, but specifically on diabetes. They get the full gamut of a diabetes kind of an internship for a full year. And then they are certified to go back and actually work in their communities as diabetologists.
Kelly, let me ask you, I know this is, I didn't have the time to prepare the answer, but I know you've been working on, with the Helmsley, educating primary care doctors about type 1 diabetes, because they do see a lot of type 1s. Any comments on that? Well, we know it's important, on that initiative that you're working on.
Oh yeah, well, you know, I think that we're at diaTribe not working so closely, but just things that we've noticed that are really helpful is, especially in this time of COVID-19, you know, there's many programs where, like, you know, 60 of you amazing doctors will be online, and you can be chatting with each other, and people can feel the community that way. And I've just gotten to see it as a patient, because sometimes they ask patients to come on. We love that. We think there's so many things about being a doctor that is also really lonely, you know? And I know the Helmsley Charitable Trust is thinking so much about mental health and, you know, better mental health for everyone and better emotional well-being. So those are some of the things that we have noticed about community.
Yeah, Will, I just got a text with a question for you. If I could jump in front of Schaefer. You know, the increase in new cases of type 2 diabetes in youth and adolescents apparently is continuing to go up, alarming rates. You know, the RISE data is really scary. What are some of your comments on that, the onset and the young and the adolescents?
Well, you've seen the search data. In fact, it was published back in February, and it's pretty disturbing about the increase in new cases, particularly for minority populations, American Indian, non-Hispanic, Black, Hispanic. And so this is not going away. And the problem is we have many studies now that have looked at type 2 diabetes in youth and adolescents, and it really is a different disease from adults. We see that from today's study, where youth failed metformin, over 50% failed, and a much greater rate than we see in adults. From the RISE, we see that there's different pathophysiology. Youth are more insulin resistant. They have greater beta cell responsiveness, yet over time, what predicts failure is they have a greater beta cell failure rate. So it really is a different disease, and trying to understand youth and type 2 diabetes in youth and adolescents is really a priority for us. But this is very important, and they get back to what we see in utero. A lot of the maternal glucose levels from the HAPO follow-up study show that, you know, maternal glycemia is associated with some of the glucose levels we see in youth and adolescents 10 to 14 years later. So it's a pretty complicated situation, but what we're seeing in youth and adolescents right now is a completely different disease, or markedly different disease, than what we see for type 2 in adults.
Yeah, that's super interesting, and that is alarming. And I was surprised by your answer. Schaefer, please go to the next question.
So this is a question that comes from Kathleen, and I'll add to it a little bit. So there was a study that was presented this year at ADA, the DAPA heart failure study, and sort of an incidental finding of sorts, or one that wasn't the primary outcome, was that there was a 32% relative risk reduction in diabetes incidence, or advancing from pre-diabetes to type 2 diabetes amongst subjects who were started on the dapagliflozin but did not actually have diabetes. So what are your thoughts just on these findings in general? And, you know, when should we be considering these types of medications, SGLT2s, GLP-1s, going even back to metformin, in terms of diabetes prevention?
Anybody want to take that as a first stab?
Well, I saw the data, and again, the reduction was pretty similar to what we'd see in metformin. But once again, this wasn't a prevention trial. I think the data is intriguing. I think we're going to have to get additional data as far as follow-up. When you look at what's done for the FINISH study, the diabetes prevention study, or some of these other drug intervention studies, these were designed as prevention studies, and this was a sub-study of a drug trial. So the data, I think, is of interest, but what would be of interest to me is that, okay, what happens when you withdraw the drug? Does the diabetes remain? Does it come back? So it's an intriguing finding. I think we need to do additional studies to determine the effectiveness of it. But again, I was intrigued by the findings, but I think there needs to be some follow-up studies to validate the findings.
Yeah, these type of findings have been discovered in so many different medications, and you're right, Will. We have a lot of drugs that can prevent diabetes as long as you still take them, and as long as you take them in the pre-diabetes state. So including ACE inhibitors and things like that. Vanita, I wanted to ask you as part of the Q&A, we didn't talk too much about SGLT2 inhibitors on the treatment algorithm, but as we all know, that first step is looking, does the patient have atherosclerotic cardiovascular disease or not? And then you go GLP-1 or SGLT2. If the person has heart failure, renal problems, then you're probably going to go with an SGLT2. What other differentiating factors do you look at that first step? And anybody else can jump in.
Yeah, I also really like to look at what the patient's history is in terms of potential side effect profile. So do they have a history of pancreatitis, in which case you would lean more towards the SGLT2? Do they have a history of frequent urinary infections or fungal infections, in which case you'd lean towards the GLP-1? The other issue I look at is what their baseline A1C is. So do you need to lower their A1C by a greater amount, in which case the GLP-1 might be more appropriate versus less reduction. So those are some of the factors. Another thing that, again, is what level do they have in terms of their kidney function and urine albuminuria, because based on data from the Credence study, we know that the SGLT2 inhibitors can prevent the primary progression of renal disease.
Yeah, that's, the Credence study was pretty impressive, but you had to have a lot of microalbuminuria in your urine. I wonder if that's applicable to all SGLT2s or even at lower levels of protein spillage, but it is impressive, and they're seeing similar benefits with other SGLT2s as well as pertaining to renal function. Okay, Schaefer is texting me. He's got a type 1 question.
Sure. So this question sort of following up on the question of prevention, but this time in type 1 diabetes. So we saw data this year on golimumab, which that's the first time I've said that out loud.
Yeah, that's obvious.
Yeah, thanks. So, and it was very intriguing data, positive data, and I think it's always exciting to see this in type 1 diabetes. And it follows, shortly on the tail of the teplizumab data. And so, these are the first time where we've sort of seen some of these medications actually show some positive results in real live humans, not in mice. So in general, what do we take away from these? Is this real change in type 1 diabetes prevention or at least early treatment? What are the takeaways?
Jeremy, you go first, and then we'll go to Earl. I know that our resident type 1 panelist here.
Yeah, I think starting with the anti-CD3 data, initially data showing that this could delay diagnosis by 2 years, now some newer data showing maybe by 3 years. And to me, that's really meaningful. Being diagnosed at age 5 versus age 8, that's a very different state to be in life. So one is just getting kids farther along in kind of development. And 2 is think about where we were in diabetes 3 years ago. And, if you could delay the disease by that long, all the new therapies that might be available, I think is really meaningful. So what's interesting to me, though, is let's say all of a sudden anti-CD3 was on the market and you had it approved for people that were at risk for type 1 diabetes. Currently, there's no infrastructure for how do we find these people that are at risk outside of TrialNet and these, large, kind of programs. So it's going to be, a new way of how do we screen people, and it's not a patient that's coming to you, it's their sister, so I have, I'm seeing a patient with type 1 diabetes. How do I screen, a family member? Can I order antibodies for them? Who does that? So I think it's going to require this whole new public health initiative of how do we appropriately identify which patients to screen, and find these people that are at risk for these new therapies. And I think, I'm hopeful that anti-CD3 will kind of usher this forward. And in doing so, will really cement this idea that type 1 diabetes is not diagnosed, with hyperglycemia. That we have people that, have type 1 diabetes for years before they become clinically, apparent. So I think now that we have therapies that can really intervene earlier, we're really going to understand the pathophysiology of type 1 diabetes a little bit better, that we have an opportunity to intervene much earlier when beta cell dysfunction and death kind of occurs. And I'm excited about that. And then in terms of the newer therapies, I think of Gollum from like Lord of the Rings when I think of Gollumab. But it's exciting to have new data that's another agent. And I think I'm jealous of all the rheumatologists and IBD.
Don't be jealous of them. Whatever you. Maybe the cardiologist, but not the rheumatologist.
Well, these autoimmune, agents they can play with and combine and do these different things. And in type 1 diabetes, we haven't had something for so long. So to eventually maybe have multiple medications that we could, combine and things like that. So bottom line is, I'm happy to see this space moving forward. I think by the next ADA we have in a year, potentially in person, we're actually going to see anti-CD3 on the market.
Earl, do you have any comments on that?
Yeah, the meeting it wasn't just the anti-CD3. We also saw a combination of IL-2 and liraglutide, and I don't know if I can say it right, golimumab. That makes so much sense to me. We've been talking about anti-TNF therapies for T1D, beta cell preservation, since Enbrel came on the market, etanercept, many years ago. That drug originally came from Seattle, the original company. I don't even remember the name. It was so many years ago. But we actually published a case report about this a few years ago. And if you understand the immunology and the cytokine attack on the beta cell, it makes sense. The problem with Enbrel was it was thought it was too dangerous for children. And now we have another drug, and maybe it's not. I think the other important points are, number one, what Jeremy said, we still, according to the search data, have the highest risk of hospitalization for DKA in the world. That's not good. So public health education is going to have to be a big issue. And then we're going to have diabetes clinics like mine and like everybody getting used to doing infusions. Because right now, we're really good at giving subcutaneous injections. Endocrinologists do infusions with their bisphosphonates. We don't do infusions, and we're going to have to get used to that. And to your point, the rheumatologists do it. We can do it.
So let me just comment. I want to follow up with what Jeremy said. And these are studies. There are many drugs now that have been shown in new onset diabetes to have beta cell or C-peptide preservation. That's very important. But what this speaks to is that the disease does not start when you have type 1 diabetes and hit the glycemic threshold. The disease starts when you have 2 antibodies, and that's stage 1. And when you have dysglycemia, stage 2. So what this allows us to do is to take these agents shown in new onset diabetes and move them earlier. And that's what's happening in TrialNet now, to now study these drugs in type 2. And Jeremy, to your point, yes, it's going to take a different screening, because where are these patients and how do you identify them outside of research trials? But it's very important to understand, you develop the disease starts when you have 2 antibodies and your glucose is normal. And that's the paradigm change.
Yeah, it's so hard to screen for folks that early. Well, Schaefer, we're gonna end our forum now with thoughts from all of our panelists of what they're hopeful for in the future. But I want to tell everybody, thanks, Schaefer. You've been well trained. You shop at the same shirt shop as Jeremy does. You guys are really good.
And I literally do. Sometimes we show up to work with the same shirt on, occasionally.
I'd like each panelist, Kelly and I would like each panelist to tell us what they're most hopeful for over the next year or in the future, and including what Kelly is most hopeful for as well. So, does anybody want to start?
I'll start. I think underscoring all of this is the importance of lifestyle change, and I think we're just starting to recognize what role that plays. And you know, we talk about socio-ecological determinants of health, of you know, having safe places to walk, having access to healthy foods, and these are not. So far, we've been focused on the medical model. We need to think about a society for a healthy future, and can't underscore that enough.
Okay.
I'll take the second one.
Thank you.
I'm most hopeful for this next year that we'll take advantage of the opportunity that we have with this virtual environment we've been thrown into, really take advantage of our diabetes educators. We have, in primary care, we have just dropped the ball on that important aspect of care management for our patients with type 2 diabetes. So I think if nothing else, if we are now engaged in a new platform of learning, that we will now take advantage of this valuable resource.
Thank you, Gene. Earl, what are you most helpful for?
Well, one of the things that I think most of you know that I have been so concerned about has been access of insulin to everybody, and we're getting there. Some of this was sort of pushed forward by COVID, and I'm not having insulin access problems with patients who were really struggling before, and that's I just hope it continues, and I think it will, and I hope we can look back at the history of this and sort of explain to the medical students and the families who are caring for it, this used to be a problem and it's not anymore. So I agree with everything Vanita said. I don't want to de-emphasize that, but from a population point of view, it's also an issue for people with type 1 diabetes. Emphasizing the exercise. Kelly, we talk about it. You talked about it, about how you can't get to that 90% time and range when you're eating junk. It's impossible. And I think the lifestyle issues, both for people who have pre-existing diabetes, no matter what type it is, and for people with pre-diabetes and people who are obese, it's a huge, huge issue. And then the final thing that I think we're going to do a better job with in the future, we are about to start an NIH study that we had our last study investigators meeting a couple of weeks ago called Radiant. And I am so excited about this, as there are so many people, and I'm watching the comments coming on my screen, and they don't really fit into what we're talking about. It's because they probably have a mutation, some genetic mutation, that their diabetes really doesn't fit because it's different. And we need to learn what those genetic mutations are so we can give you more specific therapies for your type of diabetes. And I am very confident that the smart people in Radiant are going to figure that out.
Thanks, Earl. Well, that's a good segue to Wil. What are you most excited for?
Well, let me just say that what I'm most hopeful for is that we get past the COVID-19, because we haven't talked a lot about what it's doing to individuals with diabetes, both in type 1 and type 2. And you look at some of the data that was presented in New England Journal from England about the rates of mortality in both type 1 and type 2 and the effect of hypoglycemia. It's something we haven't talked about tonight, but I'm going to be hopeful that as a society, we can address this and begin to address the issues with COVID-19 in individuals with both type 1 and type 2 diabetes. And I hope that next year in Washington, D.C., we can get face-to-face and finally have this conversation, because Earl can, again, we can talk to him in the hallway, and unlike today, I can just click him off, but in the hallway, I have to talk to him because there's no way to
Thanks, Wil. Okay, Jeremy, what are you most hopeful for?
I think, since what I do mostly is clinical translational research, what I'm most worried about right now is the impact of losing society grants like the ADA and JDRF in terms of research funding. And that's already having an immediate effect on training grants, on translational research awards, things like that I think we haven't really realized the impact that that's going to have on clinical research yet. Thankfully we still have the NIH, which thank God for that. But I really hope that we see the ADA, JREF, in the world of diabetes land on their feet, and not to mention cardiology and gastroenterology and all these different societies that fulfill a really important role in research and advocacy and all these things. So I'm hopeful next year that this is an in-person meeting, that we're kind of back to where we were in terms of meeting in person, ADA filling its niche, JDRF, all these things, that we can kind of resume these different kind of research enterprises that are so vital to diabetes.
Thanks, Jeremy. I'll go next, and I'll let Kelly finish it off. But I think we all want COVID to go away, and so I'm very hopeful that we can return to normal. But I am hopeful that we can learn that there's some silver linings in being quarantined at home and doing a lot of virtual meetings, be able to reach more and more people. I'm hopeful for type 1s that the vast majority of type 1s could have access to a CGM, still well below 50%. And that just shocks me. And I'm hopeful for those type 2s out there to somehow, with the help of educators, healthcare professionals, get engaged with their diabetes and realize the importance of why we go through the hassle of prescribing and developing drugs that not only improve their glucose, but also their heart and their kidneys. Kelly.
Wow, wasn't that a fantastic, you guys did an amazing job at that lightning round. So thank you so much to TCOYD and to diaTribe and to everybody here. I could listen to you guys forever. And so what you have made me most hopeful about is really I just want us all to get to the best time in range, locally, in our neighborhoods, in our cities, nationally, globally, all of us using the right tools. Jeff Dawkins has made us at diaTribe so smart about how we think about data and technology, and everybody has to be able to get that so we can get to the right food, we get to the right therapy, the stuff that is really foundational. And, it's really the best kind of preventive thinking, and it's the best preparedness. So on that note, thank you so much, everyone, for so much learning, and we'll be back bringing it back to you all, the learning at diatribe.org.
And next year, we'll have an open bar again. Kelly, go hug your kids. Jeremy, go hug your kids. The rest of us, our kids have grandkids. Jesus. And thanks everyone for joining. I was just talking about you. Thank you guys so much. And thanks everyone for joining.